Here today, three presentations of work group members. The first one will be by Professor Elderi and Professor Cooper-Wasser and on some safety uncertainties of COVID-19 vaccines. The second one will be by Professor Carlton about genomic of vaccine-induced myocarditis. And just to speaking to the open debate and transparency, we are going to hear later in the afternoon from members in the work group, Professor Bernstein, Professor Miglis, and Professor Perlman, that will talk about the minority opinion of the work group. Again, we are going to make sure that there is debate and it's transparent, and that's kind of the way we believe we should conduct ourselves. I want to end by thanking the other ACIP members that served with me on this work group, Dr. Pagano and Dr. Melon. And I cannot thank enough for all the external subject matter experts that participated in the work group discussions. It has been an honor for me to interact with them and a pleasure. And they all worked very, very hard on a very, very impossible timeline. And this is also an opportunity to thank our colleagues at the CDC and FDA that worked also their butts off, again, in some kind of an impossible timeline that was forced on us by the circumstances. And finally, I want to thank the two ex officios that participated in the work group, Dr. Hogg and Dr. Johnson. Again, I look forward to hear everybody today and have a good debate. Thank you.
Thank you for that, Dr. Oliva. We now have three presentations by Dr. Srinivasan from CDC.
Yeah, answer. Thank you. Go a lot faster. All right, good morning. My name is Dr. Arjun Srinivasan. I'm the Acting Chief Medical Officer for CDC's National Center for Immunization and Respiratory Diseases. I'll begin today with updates to COVID-19 epidemiology. I'll note that as yesterday, I am joined by subject matter experts on the line to respond to questions. And I will also note that I have been asked to move very fast, so buckle up. The data presented and discussed in this section will be data from the COVID-19 Associated Hospitalizations Surveillance Network, or COVIDNet. COVIDNet is one of three RESPNet platforms, in addition to RSVNet and FluServeNet, that collect data using similar methods and catchment areas on laboratory-confirmed COVID-19, RSV, and influenza-associated hospitalizations, respectively. It is a collaborative effort between CDC and state and local health departments who share data with CDC via cooperative agreements. COVIDNet is a population-based surveillance system that collects and reports data from more than 300 acute care hospitals in 185 counties across 13 states. The COVIDNet catchment area includes about 10% of the U.S. population. COVIDNet collects and reports two types of data. The first type of data are population-based rates of COVID-19 associated hospitalizations. These include all hospitalizations that meet the COVIDNet case definition of a laboratory-confirmed SARS-CoV-2 positive test among hospitalized residents of the COVIDNet catchment area. COVIDNet collects and reports some data for all cases, including age, sex, race, ethnicity, site, and test and admission dates. The second type of data describe clinical characteristics of hospitalized patients, including outcomes, underlying conditions, treatments received, and discharge diagnoses. These data are obtained through detailed medical chart reviews of an anonymized site and age stratified random sample of hospitalizations. When presented in reports or presentations, clinical analyses are limited to hospitalizations due to COVID-19, the definition of which will be presented later. The primary purpose of COVIDNet is to monitor laboratory-confirmed COVID-19 associated hospitalizations among children and adults and deliver these data to decision makers and the public in order to provide a broad and timely understanding of COVID-19 trends. COVID-19 associated hospitalization rates are updated weekly and are used to estimate and compare disease burden and respond to rising rates. Detailed clinical data, including underlying conditions, allows CDC to categorize hospitalizations that are due to COVID-19, better understand COVID-19 associated hospitalization trends and determine who is most at risk, track severity of illness, examine how many people hospitalized due to COVID-19 have underlying medical conditions, and provide insights into treatments used. When defining COVID-19 associated hospitalization in COVIDNet, a case is counted if the person lives in the defined COVIDNet catchment area and tests positive for SARS-CoV-2 using a laboratory-based molecular antigen or serology test within 14 days before or during hospitalization. This definition is used to monitor overall trends in hospitalizations. The surveillance definition is a simple approach that works across hundreds of hospitals and is available in near real time. Similar definitions are used to monitor hospitalizations for other pathogens like RSV and influenza in the US and worldwide. This approach was developed by infectious disease experts, and the surveillance definition has met the balance needs of accuracy, speed, and broad coverage over COVIDNet's 5-year existence. There has been sustained interest in determining whether hospitalizations among SARS-CoV-2 positive persons are with or for COVID-19 related illness. During the early pandemic with asymptomatic transmission, no immunity or vaccinations, and high rates of illness, hospitals screened every patient when they arrived at the hospital. The screening likely identified hospitalizations among SARS-CoV-2 positive asymptomatic patients or persons with COVID-19 illness who were hospitalized for other reasons, like surgery or labor and delivery. As a result, COVIDNet implemented an algorithm to track cases with COVID-19 identified as the likely primary reason for admission, hereafter referred to as hospitalizations due to COVID-19, using chief complaint and history of present illness. Data for all current and previous surveillance periods back to March 2020 are posted monthly on COVIDNet's public dashboard. It is our understanding that this topic was of interest to the committee. Of note, while widespread screening of every patient for COVID has largely stopped, COVIDNet continues to use the algorithm. Before going further, we should describe some of the factors to consider when defining hospitalizations due to COVID-19. Regardless of the focus, identifying a singular cause of hospitalization can be difficult for several reasons. A positive SARS-CoV-2 test can influence the decision to admit a patient who has comorbidities or other conditions. Additionally, the presence of comorbidities or other conditions can influence the decision to admit a SARS-CoV-2 positive patient. Many data elements extracted from the medical chart, including SARS-CoV-2 testing, treatment, discharge diagnosis codes, and other data elements can misclassify hospitalizations with respect to whether or not they are due to COVID-19. For example, ICD-10-CM codes in the US are designed for administrative and billing purposes, not surveillance, and may overcount or undercount cases. Additionally, the COVID-19 ICD code can be used just to indicate a positive SARS-CoV-2 test. COVIDNet uses a rigorous and standardized process to determine whether sampled hospitalizations can be classified as being due to COVID-19. As mentioned, this approach relies on abstraction of the chief complaint and history of present illness at admission from the medical record. This slide describes the algorithm used to define hospitalizations where COVID-19 was the likely primary reason for admission. First, hospitalizations are classified as non-COVID-19 related if the history of present illness indicates obstetric care, such as labor and delivery, an inpatient surgery or procedure, a psychiatric admission, trauma, such as fracture or car crash, or newborns hospitalized at birth. For the remaining hospitalizations, if the chief complaint or history of present illness documents fever or respiratory illness, a COVID-19-like illness, or suspicion for COVID-19, the hospitalization is classified as having a COVID-19-related reason for admission. A small subset of hospitalizations that do not clearly fit these categories are reviewed by 2 COVIDNet physicians with adjudication by a third if necessary. If the medical record indicates that the positive SARS-CoV-2 test results was an incidental finding or that the hospitalization was not related to COVID-19, such as for a localized infection or surgical complication, those hospitalizations are classified as not being related to COVID-19. This figure shows the percent of hospitalizations due to COVID-19 based on reason for admission over time by age group. Using the algorithm, 87% of hospitalizations among SARS-CoV-2 positive admissions identified by COVIDNet were due to COVID-19. Percentages have increased over time, likely because widespread screenings of asymptomatic patients are no longer occurring. The percent of COVID-net hospitalizations due to COVID-19 was 89% for children, and the percent increased with age among adults. Adults aged 65 years accounted for 70% of COVID-19 associated hospitalizations, of which 91% had COVID-19 as the likely reason for admission. As a collaborative surveillance system, COVID-net must balance the burden of chart abstraction with the utility of clinical data. There are limitations to what can be collected and reported, as well as how and when. Because ICD-10 coding occurs after patient discharge, reporting can be delayed, and in some cases, final ICD-10 codes may be stored only in billing systems that are not accessible to abstractors. To address these challenges, COVID-net surveillance officers also review each patient's discharge summary. This allows them to capture conditions that were not present on admission, but developed during the hospital stay. By combining discharge summaries with available ICD-10 CM codes, COVID-net provides a fuller picture of the hospitalization and reduces some of the bias that comes from relying on billing codes alone for public health surveillance. This chart walks through the percent of COVID-net hospitalizations that are classified as either due to COVID-19, shown in the blue boxes, or with COVID-19, shown in the red boxes, using two approaches. On the left, COVID-net hospitalizations are classified using ICD-10 CM codes and discharge diagnoses. On the right, they're classified using COVID-net's reason for admission algorithm. We're using data from the 2023-24 season, as ICD-10 CM codes are not available for the ongoing 24-25 surveillance season. During this period, COVID-net identified more than 66,000 hospitalizations among patients of all ages. Of those, 7,279 were sampled for abstraction of clinical data from the medical record. Starting in the boxes on the left, this flowchart examines the presence of the COVID-19 ICD code or sepsis or respiratory-related discharge diagnoses among all sampled COVID-net hospitalization. Of them, 81% had a COVID-19 ICD-10 discharge diagnosis in any of the first 9 coding positions, which capture both the principal diagnosis and the most important contributing diagnoses. 52% had a sepsis or respiratory-related discharge diagnosis, and 88% had either a COVID-19 ICD-10 code or a respiratory discharge diagnosis, as shown in the dark blue box on the left. And as shown in the red box on the left, 12% of cases had neither a COVID-19 ICD-10 code nor a sepsis or respiratory-related discharge diagnosis. Moving to the boxes on the right, this flowchart describes how COVID-net defines hospitalizations due to COVID-19, applying the reason for admission algorithm to the same sampled hospitalizations. Of them, 85% had hospitalization due to COVID-19 based on reason for admission, as shown in the blue box on the right. Of those, 91% had either a COVID-19 ICD-10 code or a sepsis or respiratory diagnosis, the same criteria used in the flowchart on the left. Of the remaining 15% who had a non-COVID-19 reason for admission, shown in the red box on the right, 64% also had a COVID-19 ICD-10 diagnosis code. In summary, the two approaches to classify hospitalizations as being due to COVID include identifying COVID-19 as the likely reason for admission or identified COVID-19 related discharge diagnoses. These two methods show very strong agreement, with 88% of all hospitalizations having a COVID-19 ICD-10 code or sepsis or respiratory diagnosis, and 85% identified as having COVID-19 as likely primary reason for admission. 92% of hospitalizations using COVID-net's reason for admission approach had a COVID-19 ICD-10 CM code or sepsis or respiratory-related diagnosis. COVID-19's reason for admission approach is more conservative than examining discharge diagnoses, and more importantly, can be completed in a timely manner. Given the similar findings, these results give us confidence that COVID-net strikes the right balance in terms of timeliness, accuracy, and representativeness of the population. This figure shows the rates of COVID-19 associated hospitalizations per 100,000 population by age group. These are cumulative rates and represent the cumulative risk of hospitalization by age group for the 12-month period of October 2024 through September 2025. As a reminder, these rates are based on the surveillance standard of a positive SARS-CoV-2 test among hospitalized residents of the surveillance catchment area. The cumulative rates for hospitalizations are highest among adults 65 to 74 and 75 years and older, as well as among infants less than 6 months of age. Unlike older adults, there has never been an approved vaccine products for infants less than 6 months. Any immunity to reduce the risk of hospitalization would need to be provided through maternal vaccination. This figure shows the percent of hospitalizations due to COVID-19 that resulted in severe in-hospital outcomes by age group, including admission to the intensive care unit or ICU in tan and in-hospital death in red. A significant proportion of adults hospitalized due to COVID-19 experienced severe outcomes, with 15% of adults having been admitted to the ICU. In-hospital death is more common among adults 50 years of age and older. As noted in the yellow box on the bottom, 84% of all adults hospitalized due to COVID-19 who died in hospital were 50 years of age and older. Note that these are only in-hospital deaths. We know that COVID-19 associated deaths occur outside the hospital, including some that occur within 30 days of hospital discharge. Note that different respiratory viruses affect different age groups differently, with the biggest collective impact at the extremes of age. This figure shows cumulative rates of laboratory-confirmed hospitalizations for COVID-19, influenza, and RSV. As you can see, RSV in yellow contributes to the highest burden of respiratory disease in children less than 1 on the left. But COVID-19 has an outsized impact on older adults. However, COVID-19 is not inconsequential in infants, with hospitalization rates comparable to rates of influenza hospitalization. As mentioned, this figure represents the cumulative rates of hospitalization since October 2024. Finally, it is important to note that the rates were in the context of a high-severity influenza season, with cumulative overall rates of influenza hospitalization the highest experience since the 2010-2011 season. On this slide, the larger figure shows cumulative rates of COVID-19 hospitalization by age group, with a focus on those less than 75. The rates of hospitalizations among infants ages less than 6 months remain close to those among adults ages 65 to 74 years throughout the season. The rates have diverged in recent weeks, with rates increasing among infants at a faster slope compared to adults 65 to 74, with current cumulative rates of 223 and 194 per 100,000 respectively. The cumulative rates during this period among infants less than 6 months are 14% higher than adults aged 65 to 74 years. The inset figure in the red box includes these same rates in addition to adults ages 75 years and older, indicated by the orange line. As background, this analysis on chronic conditions is an update to a peer-reviewed manuscript published in 2021. The results of that analysis informed the infographic pictured here, which summarizes the relative risk for hospitalization among persons with the specified conditions to those without. The data sources for this analysis were threefold and include COVIDNet data on the number of hospitalizations due to COVID-19 from October 2022 through September 23. Data on the prevalence of chronic conditions were from the Behavioral Risk Factor Surveillance System, or BRFSS, the largest continually conducted health survey system in the world, with hundreds of thousands of interviews among community-dwelling U.S. adults administered each year. Population data from the U.S. Census were provided by the National Center for Health Statistics. The methodology used for the analysis is complex, but in short, COVIDNet was used to obtain weighted counts of persons hospitalized due to COVID-19 with and without underlying conditions. COVIDNet data were limited to hospitalizations with COVID-19 as likely primary reason for admission, as previously described, and limited to community-dwelling adults, as BRFSS is only administered to community-dwelling adults age 18 years and older. Weighted counts of community-dwelling adults with and without chronic diseases of interest in participating states were calculated using BRFSS data. Using state populations and statistical modeling, adjusted rate ratios of hospitalization rates with versus without chronic conditions were calculated. The chronic conditions examined were limited to those conditions included as part of the BRFSS interview and are listed here. This figure shows the prevalence of chronic conditions examined among adults admitted for COVID-19 in blue compared to the general population of the COVID-net states in gray. The prevalence of most chronic conditions among adults hospitalized due to COVID-19 was generally higher than the prevalence observed in the general population. This chart shows the rate ratios of chronic conditions comparing adults hospitalized due to COVID-19 with the condition to those without by age group. Among adults, most chronic conditions examined increased the risk of being hospitalized due to COVID-19. The risk conferred by several conditions appeared to decline with age, including coronary artery disease, diabetes, and obesity. This might be a consequence of an inability to adjust for comorbidities in the models, or low population prevalence of some conditions in some age groups. For example, severe obesity is uncommon among adults aged 75 years and older, and COPD is uncommon among adults younger than 50 years of age. Additionally, this analysis shows risk for hospitalization due to COVID-19 increases with the number of chronic conditions and age. Having multiple comorbid conditions and older age were the strongest risk factors for COVID-19 hospitalization among adults. As shown in the red box, adults with 3 or more underlying conditions are nearly 6 times more likely to be hospitalized due to COVID-19 compared to those with no underlying conditions. As shown in the blue box, hospitalization rates were 18.5 times as high among adults aged greater than 75 years compared to adults aged 18 to 49 years. Being aged 75 years or more was the greatest risk factor examined in this analysis. This analysis has many strengths. The data are gathered from a robust COVID-19 hospitalization surveillance system. This allows us to compare underlying conditions using state-level prevalence data and to examine how specific underlying conditions, the presence of multiple conditions, and age groups contribute as risk factors for COVID hospitalization. That said, there are limitations. Results are still preliminary and remain under review. As previously noted, this analysis is limited to community-dwelling adults to align with the population from which we have BRFSS data on chronic conditions. The risk for hospitalization due to COVID-19 among children or among non-community-dwelling adults, like those who live in long-term care settings, could not be examined and might be different from those presented. Some underlying conditions tend to co-occur, such as diabetes and chronic kidney disease. Adjustments for some comorbidities, such as adjusting for chronic kidney disease among persons with diabetes, could not be made due to sparse data, especially in younger age groups. Additionally, this analysis was not able to look at differences in rate ratios across outcomes, such as ICU admission or race and ethnicity categories, due to sparse data. And I don't know if we want to pause here for questions, Martin, or move, or Retzef, sorry, do you want to move on to the next presentations?
Yeah, please move on to the next
Okay.
presentation.
Can we have the next presentation, please?
I object, Martin. I've got some really concrete questions I'd like to ask. Could I have permission?
Please, Dr. Malone.
So as I understand it, and this relates to information that was presented by the CDC to the subgroup, help me to understand, there is significant overlap and challenge in the clinical diagnosis of COVID-19 as opposed to other, let's call them influenza-like illnesses. Is that true or false?
Meaning that the symptoms of COVID-19 overlap with symptoms for other respiratory infections?
Almost completely.
I would say that's true.
Okay, thank you. Number 2, when I queried the CDC representative on the specificity and sensitivity of the testing being used, which is the other key leg of your whole data set, what she told me was sensitivity and specificity in this context were academic. Now, as somebody trained in pathology, who taught pathology for years, I object to that. My point is, it's lovely that you created all this data, but the 2 underlying theses that underpin all your data are tenuous. And in the case of the diagnostic testing, as has been widely noted, the diagnostic testing for COVID has had significant problems with specificity and sensitivity. and that's not factored into the model. Is that true or false?
Let me ask one of the subject matter experts to comment on sensitivity and specificity of the tests used in the model. Thank you.
This is the NCIRD SME room. The tests used in COVIDNet are the FDA-approved tests that are performed in hospitals and medical clinics across the country. We do not perform testing as part of the COVIDNet surveillance. Those are all clinically tests that are done at the clinical discretion of the provider seeing the patients.
Right. So what you're admitting or acknowledging is that all those tests have issues with sensitivity and specificity that will affect the interpretation of these data. True?
Hi, any test that is performed clinically has sensitivity and specificity values. These are FDA-approved tests that are used to identify patients who test positive for SARS-CoV-2.
But if they're only 80% specific, therefore as one example, your underlying thesis about what is a COVID case or not a COVID case inherits a similar level of ambiguity. True or false?
This is Natalie Thornburg, Lab SME and NCIRD. FDA has, and I'm not speaking for FDA, but FDA, all of the tests that have been used in COVIDNet, again, have been received FDA approval through CDHR, and they have baseline specificity and sensitivity requirements, and the specificity has to be above 90%, I believe, and sensitivity similar.
Thank you.
Dr. Srinivasan has actually 3 parts to his presentation. So the idea is to let him do all 3 parts before we have a question and answer. So if you have question and answer, we are noting that on the list here, and we will do that in the order as you request them, but we will continue with the other 2 sections of his presentation before we take more questions and answers. So
Perfect.
Please go ahead,
All right.
Dr. Srinivasan.
Thank you. Let's move on to COVID-19 vaccine implementation. Okay. Maybe this. Okay. Oh, sorry. Wrong one. All right. Before I discuss COVID-19 vaccination coverage, I thought it would be helpful to explain the sources of the data I will present. One of the data sources the Immunization Services Division uses to obtain data on vaccination coverage, like COVID-19 vaccination, and other information on immunization implementation is the National Immunization Survey, or NIS. The NIS is a random digit dial cellular telephone survey of adults age 18 years and older in the US, local jurisdictions, and associated territories. Data for children are reported by their parent or guardian. All responses are self-reported. The sample size is approximately 15,000 adults weekly or 60,000 adults monthly. Data are weighted to reflect the non-institutionalized US population. This slide shows 2024-2025 COVID-19 vaccination coverage for at least 1 dose among adults 18 to 49 years, 50 to 64 years, and adults 65 years and older in the top dark blue line from September 2024 through April 2025. Vaccination coverage among older adults reached 44% for 1 or more doses, 25% for adults 50 to 64, and 14% for adults 18 to 49. Oops. Yeah. Sorry, I'm going to shoot the slides here. COVID-19 vaccination coverage increased for older adults. Let me see that. No. Increased for older adults between the 2023-2024 seasons and 24-25. The first graph is among adults 18 to 49 years. The second graph is among adults 50 to 64 years. The third graph is among adults 65 to 74 years. And the final graph is among adults 75 years and older. For the first two age groups, you see that vaccination coverage was the same for the two seasons. For those 65 to 74 years of age, vaccination coverage rose almost 5 percentage points in the most recent season, while for adults 75 years and older, coverage improved by about 8 percentage points by the end of the 24-25 season. Note these differences are statistically significant in 65 to 74 and 75 and older age groups to less than 0.5. This slide shows COVID-19 vaccination coverage estimates for the pediatric population. Approximately 5.6% of children less than 4 years of age were up to date with COVID vaccination, according to current recommendations for that age group, shown in light blue. In children 5 years and older, up to date is defined as receipt of at least one vaccination since August. For children between 5 and 17 years of age, almost 16% have received at least one dose. Overall, approximately 13% of children between 6 months and 17 years of age were up to date with their COVID vaccinations at the end of April 2025. For immunocompromised adults age 18 years and older who received their first COVID vaccine dose in August or September of 2024, 8% were fully vaccinated with 2 doses by the end of March. When coverage is stratified by age, 16.6% of those in the 50 to 64-year age category were fully vaccinated, compared to 2.4% in the 18 to 49-year category, and only 0.8% in the 65-year and older category. In summary, COVID-19 vaccination coverage for older adults improved in 24-25 compared to the previous season. Vaccination coverage for adults 18 to 64 years was similar between seasons. Approximately 13% of children between 6 months and 17 years of age were up to date with COVID vaccinations at the end of April 2025. This slide shows the place of vaccination for adults 18 years and older. This was asked among persons who reported receiving a 24-25 COVID-19 vaccination since August 2024 for an N of 9,359. These data were collected between April 1st and April 27th of 2025. The majority of adults, that is 67%, reported receiving their vaccine in a pharmacy or drugstore location. About 29% received their vaccine in a medical place, such as a doctor's office. About 4% received their vaccine in a non-medical place, such as the workplace. I'll now share data on vaccination in healthcare personnel collected through CDC's National Healthcare Safety Network, or NHSN. NHSN is the nation's most widely used healthcare-associated infection tracking system and provides important process measures like healthcare personnel vaccination status. CMS-certified skilled nursing facilities and hospitals report COVID-19 and influenza vaccination data for healthcare personnel. Data collected through NHSN show that influenza vaccination rates in acute care hospital staff, the red triangles, and long-term care staff, the gray X's, have remained fairly consistent from 2022, when NHSN first started collecting healthcare personnel vaccination data, through the most recent respiratory virus season, 2024 to 25. COVID vaccination coverage, however, continues to decline across seasons in both the acute care, blue boxes, and long-term care settings, the gray diamonds. And we'll move on. Can we have the last presentation in this group, please? Yeah, take a drink of water while there. I'll first review methods for vaccine effectiveness, or VE, then share some results on VE for children, maternal VE, and VE for adults. Note that some of these slides were previously shared at the June ACIP meeting. Today's presentation is a summary of the data with additional methods information in the presentation and additional methods and data included in backup slides available on the CDC's website. First, it's important to differentiate between data from randomized controlled trials and real-world evidence. Randomized controlled trials are needed to demonstrate vaccine efficacy for licensure of new vaccines and answers the question, does vaccination prevent disease under ideal and controlled conditions? That is, compared to a placebo or a different vaccine. Observational studies provide real-world evidence of vaccine effectiveness, or VE, and answers the question of whether vaccines protect against disease in the population. For COVID-19, vaccine effectiveness measures the benefit of current vaccination in a population with existing levels of protection due to prior infection, vaccination, or both. Importantly, efficacy and effectiveness are population-level estimates. If a vaccine has an effectiveness of 80%, it does not mean that the vaccine will only work 80% of the time. It does mean that in a vaccinated population, 80% fewer people will have the outcome of interest when they are exposed to the virus compared to the unvaccinated population. VE can be measured using study designs across a spectrum from a case control to a cohort. In a case control study, controls are generally sampled from the same population that gave rise to the cases. The controls are meant to be similar to cases, usually by geography or other demographic characteristics, and give an estimate of the vaccine coverage in the population where the cases originated. On the other end of the spectrum, a cohort includes an eligible at-risk population that is followed to see who develops or does not develop disease. A test negative design, or TND, takes pieces of both case control and cohort studies and, depending on the specific design characteristics, can be more akin to a case control or more akin to a cohort study. In a TND, controls can be sampled or include the entire eligible at-risk population. For respiratory viruses, CDC and many other countries generally use a test negative design to measure vaccine effectiveness. In the test negative design, people who seek care for a respiratory illness are included. Cases are those who test positive for SARS-CoV-2, and controls are those who test negative. Controls in these studies are meant to represent the population from which the cases arose and give us an understanding of COVID-19 vaccine coverage among people seeking care for respiratory illness. We then compare vaccination status in cases and controls to determine vaccine effectiveness, or VE. If coverage is higher among controls than among cases, that indicates the vaccines are associated with protection against disease. Because both cases and controls are people seeking care for respiratory illness, we can reduce the impact of factors that can distort or confound the relationship between vaccination status and illness. Reducing the impact of or adjusting for factors like age and geography helps reveal the true relationship between vaccination status and illness. There are strengths and limitations to all study designs. The test negative design is meant to leverage strengths of both case control and cohort studies and also mitigate some potential limitations of these traditional designs. A test negative design, like a case control study, starts at the diagnosis of the disease of interest, making it useful for rare outcomes, including many infectious diseases. Unlike a case control, however, the test negative design controls for health-seeking behavior by selecting controls with respiratory symptoms from the same health facility as the cases. This feature also reduces cost and increases the speed of a test negative design, allowing for results within the same season. Additionally, when a test negative design is conducted in a hospitalized population, it helps mitigate healthy vaccinee bias because both cases and controls are hospitalized for respiratory illness. Finally, test negative designs that leverage the entire eligible at-risk population for controls, usually by using electronic health record data, allowed for large sample sizes, increasing ability to assess outcomes stratified by important factors such as age or time since vaccination. Today, I'll be sharing VE results from 3 CDC study platforms for children and adults. The first VE platform is the VISION Network, a multi-site network of electronic health records at over 300 emergency departments and urgent care clinics and over 200 hospitals that includes both children and adults. Vision uses a test negative design and includes eligible people of all ages with COVID-19-like illness and a clinical test result within 10 days before to 72 hours after their encounter. Cases are those with a positive NAT or antigen test for SARS-CoV-2 and no positive RSV or influenza test results. Controls are those with a negative nucleic acid amplification test or NAT for SARS-CoV-2 and no positive NAT test for influenza or RSV, depending on age. Vaccination is documented by electronic health records and state and city registries. The second VE platform enrolls only children with enrollment at 26 pediatric hospitals in 20 states. The analysis I'll present today was designed to assess the effectiveness of COVID-19 vaccination in pregnant women for prevention of COVID-19 related hospitalizations in infants less than 6 months of age. The third platform included today is the Ivy Network, a multi-site VE platform in 26 hospitals in 20 US states that, like Vision, uses a test negative design. Unlike Vision, Ivy uses an active enrollment design with patient interviews and nasal swabbing of enrollees. Participants included in analyses presented today were adults, ages greater than 18 years, hospitalized with COVID-19-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test, and controls were negative for SARS-CoV-2, influenza, and RSV by RT-PCR. Vaccination history is ascertained through electronic medical records, state and local vaccine registries, and plausible self-report, and specimens are collected for central testing and sequencing. How we've measured COVID-19 VE is changed by season. When COVID-19 vaccines were first released, we measured absolute VE, which compares the frequency of health outcomes in vaccinated versus unvaccinated people. During the bivalent era, however, we also measured relative VE, which compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine. For example, people who received a bivalent dose versus those who received only the original monovalent COVID-19 vaccine. Generally, more recently, we have looked at seasonal vaccine effectiveness, which is similar to how annual flu VE is calculated. Seasonal VE compares people who received this season's COVID-19 vaccine to people who did not, regardless of past COVID-19 vaccination. This slide shows 2023-24 COVID-19 vaccine effectiveness against emergency department and urgent care encounters, including data through August 2024, which is when the 24-25 vaccines were released. Note that the referent group includes all individuals who did not receive a 23-24 COVID-19 vaccine. For those aged greater than 5 years, this includes unvaccinated persons and persons who were vaccinated with greater than one original monovalent or bivalent COVID-19 doses. For those aged less than 5 years, both those in the referent group and those in the vaccinated group were required to have completed an initial series. The 23-24 dose could have been part of the initial series or in addition to the initial series. In the top block, you see counts of encounters, cases, and time since dose for people who did not receive a 2023-24 COVID-19 by age group, 9 months to 4 years, 5 to 17 years, and adults 18 and up. The middle block shows VE among those who received a 23-24 dose 7 to 59 days earlier, and the bottom is VE among those who received a dose 60 to 299 days earlier. Note that there are not enough children vaccinated 60 to 299 days earlier with positive SARS-CoV-2 tests to split the 60 to 299 day block in children more granularly. You can see that VE is estimated to be as good or better among children as it was among adults. This aligns with previous seasons showing generally comparable VE across age groups. This slide is similar to the previous one, though now showing VE during the 24-25 season. Lower numbers of COVID cases in 24-25 compared to 23-24 and overall low COVID-19 vaccination coverage in children resulted in less statistical power during the season, so we were not able to estimate VE by time since dose for 24-25. Instead, we've shown overall VE for the 7 to 179 days since receipt of a 24-25 COVID vaccine dose. You can see that, as with 23-24, VE is the same or higher in children as in adults. This slide shows VE of receipt of a 23-24 COVID-19 vaccine during pregnancy for protection against emergency department urgent care visits by pregnancy status. In the top block, you can see VE among women who were pregnant at the time of their COVID-like illness encounter, and in the bottom block, among non-pregnant women of the same age. Time since dose was similar across the two groups, with confidence intervals for VE that entirely overlapped, showing that protection is similar among pregnant and non-pregnant women. This slide shows estimates of the effectiveness of maternal COVID-19 vaccine receipt for protection of COVID-19 associated hospitalization among infants from the Overcoming COVID-19 Network during 2022 to 23. Maternal VE for infants is particularly important because infants under 6 months of age are not eligible for COVID-19 vaccination and have higher rates of severe COVID-19 than older children and most adult age groups. Vaccination of pregnant women is the only way to protect their infants from severe COVID-19. This analysis included mothers who received their last dose of a COVID-19 mRNA vaccine between the first day of pregnancy and 14 days before delivery. The comparison group was mothers who did not receive any COVID-19 vaccination, either before or during pregnancy. As you can see, VE was highest in the youngest children at 54% during the first 0 to 2 months of life and 35% during the first 0 to 5 months of life. This mirrors pattern in older children and adults where VE drops with more time since dose. This slide shows VE against COVID-19 associated hospitalization among adults aged 65 years and up without documented immunocompromising conditions in the VISION and IV networks. The slide is laid out the same as the previous slides, except instead of age groups, it shows VISION adults in the top block and IV results in the bottom block for adults aged 65 years and up. VE was almost identical across the two networks, providing reassurance of the results. During the 7 to 179 days since the dose, the point estimate was 44% in VISION and 46% in IV. VE started at 46% in VISION and 42% in IV, declining to 32% in VISION and 40% in IV during the 120 to 179 days after vaccination. Though note that the confidence intervals for this time period are wider due to smaller numbers of both cases and controls vaccinated 4 to 6 months before their encounter. This slide shows VE against COVID-19 associated critical illness in VISION and IV. VISION, on the top, defines critical illness as admission to intensive care or in-hospital death, and estimates are shown by time since dose among those 65 years and up. You can see that the point estimates do not change much over time, even in the longest time since dose strata, 120 to 179 days since the dose, indicating relatively durable protection. This mirrors what we've seen in previous years. VE against the most severe outcome remains most durable over time, with little evidence of waning in the longest time since dose period. In IV, shown on the bottom, we have VE against 3 separate outcomes, all shown for the 7 to 179 days since a dose, shown generally by increasing severity, including acute respiratory failure, ICU admission or death, and invasive mechanical ventilation or death. Here again, we see indications of higher VE for the most severe outcomes at 70% for invasive mechanical ventilation or death. Among adults aged 65 years and up with immunocompromising conditions in VISION and IV. Though IV did not have enough statistical power to estimate VE by time since dose in this group, In vision, VE appears to be increasing over time, which is something we've seen previously in adults with immunocompromising condition and is likely due to faster waning of infection-induced immunity in the immunocompromised people, which would make the referent group, those who did not receive a 24-25 vaccine, have less protection over time since the summer surge, thereby appearing to increase VE. VE for the overall time period, 38% in vision and 36% in IV, is close to VE in non-immunocompromised adults, providing reassurance that the vaccine is working in immunocompromised adults. For the respective year, compared to no in-season dose, COVID-19 vaccination provided additional protection against COVID-19 associated emergency department and urgent care visits among children. Protection was similar across age groups. COVID-19 associated emergency department and urgent care visits among adults. COVID-19 associated hospitalizations among adults aged greater than 65 years with and without immunocompromising conditions, and COVID-19 associated critical illness among adults aged greater than 65 years. Protection appeared to be higher and more durable against critical illness compared to less severe outcomes. VE should be interpreted as the added benefit of the 23-24 or 24-25 COVID-19 vaccination in a population with high levels of infection-induced immunity, vaccine-induced immunity, or both. Prior SARS-CoV-2 infection contributes protection against future disease, though protection wanes over time. An increase in SARS-CoV-2 circulation in the United States during late summer 2024, just before the 24-25 COVID vaccines were approved and authorized, may have resulted in higher population-level immunity against JN1 lineage strains, which could have resulted in lower measured VE than in a population with less recent infection. And I'd like to thank the numerous colleagues from CDC and collaborators within the Vision, IV, and Overcoming COVID-19 networks who contributed to the presentation.
Yes, so we will take the Q&A later. We'll move on directly to Dr. Su. Thank you.
I'm sorry, so we're moving straight on to the, okay.
Thank you.
Sure.
Guessing I don't slide.
Yeah, she's working on it. Yeah, she's working on it.
Here we go. Thank you. So good morning. The ISO was asked to present an overview of how vaccine safety signals are detected and evaluated. Oh, there we go. This presentation will first define some terms and describe conceptually how a safety signal is detected and evaluated. A real-world example from the Vaccine Safety Data Link will then be used to illustrate how this process works in a CDC surveillance system. An adverse event following immunization is defined as any untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the usage of the vaccine. This slide provides the definition of a signal. In brief, a signal is information that arises from one or multiple sources, which suggests a new, potentially causal association between an intervention and an event that is judged to be of sufficient likelihood to justify verificatory action. This figure illustrates the concept of signal detection and evaluation and begins with signal detection. Detection of a signal might occur through clinical observations, such as case reports, or through safety surveillance systems. If further assessment of initial information continues to suggest a potential association between a vaccine and the adverse event, the next step is to perform a hypothesis testing study that attempts to either verify or rule out the signal. If the signal, based upon evidence, is verified as causally associated with vaccination, public health action or further studies might follow, such as evaluation of biological mechanisms or prevention strategies. For context, CDC has 4 complementary systems that work together to detect and evaluate potential vaccine safety concerns. The following example comes from the Vaccine Safety Data Link, or VSD. The next section of this presentation walks through an example of signal detection and evaluation. As a reminder, the VSD is a collaboration between CDC and several integrated healthcare organizations with a combined population of more than 15 million people. The VSD conducts active surveillance using electronic medical record data to detect signals and can also evaluate signals using more robust study designs. The VSD uses data that was collected as part of routine healthcare activities and links together vaccination records, healthcare encounters, and patient characteristics into a common data model for use in epidemiologic analyses. The VSD uses rapid cycle analysis, or RCA surveillance, to monitor a limited set of pre-specified adverse events of special interest, with potential cases of those events identified using ICD-10 codes for healthcare encounters. The RCA method is designed to detect statistical signals, or a finding from an analysis in which a test statistic exceeds a specified statistical threshold. A statistical signal does not necessarily represent a vaccine safety problem and requires further assessment before conclusions can be drawn. Since 2020, VSD has performed RCA using a vaccinated concurrent comparator method. The vaccinated concurrent comparator method compares the incidence of an adverse event during a risk interval, such as 1 to 21 days post-vaccination, to the incidence during a control interval, such as 43 to 63 days post-vaccination. This method inherently adjusts for calendar time and also controls for age, sex, race, and VSD site. Detection of statistical signals using the RCA concurrent comparator method is intended to be rapid, but might have residual bias. When a statistical signal is detected, the VSD can evaluate the signal using a different method, known as self-controlled case series. This method requires waiting for complete accrual of follow-up time, but is less prone to bias. This slide shows a list of pre-selected adverse events of special interest for COVID-19 vaccines, monitored by multiple U.S. federal vaccine safety systems. Non-hemorrhagic stroke, also called ischemic stroke, is an outcome that has been monitored by VSD for potential statistical signals since 2020. VSD has monitored the risk of ischemic stroke following each dose of COVID-19 vaccine as additional doses were authorized and recommended over the last 5 years. A statistical signal for ischemic stroke was detected for the first time during 2022 through 2023. A statistical signal was also detected for the 2023-2024 vaccine formulation. This graph, previously presented at an ACIP meeting in 2023, shows how the initial VSD RCA statistical signal for ischemic stroke progressed over the course of the 2022 to 2023 season. The graph shows the time period from October 2022 to April 2023. Sequential analyses were performed each week as data accumulated over the course of the season. As more people were vaccinated, post-vaccination follow-up time accrued. The gray line shows how the rate ratio estimate changed over time, from a higher value that was statistically significant early in the season to a final value of 1.26 during the last week which was no longer statistically significant. CDC and FDA worked together during 2023 to further evaluate and communicate about this signal to the ACIP and to the public, as shown by the FDA webpage on this slide. The VSD was the only vaccine safety system to signal for ischemic stroke. Other analyses in the US and in other countries had not observed similar findings. The interpretation at the time was that the evidence did not support the existence of a safety concern. The VSD-RCA statistical signal for ischemic stroke in 2022 and 2023 was specifically detected among people aged 65 years and older following the Pfizer vaccine. Further assessment of data at the time also examined the effect of same-day administration with influenza vaccine. VSD-RCA surveillance during 2023 through 2024 also detected statistical signals for ischemic stroke. However, these signals were for ischemic stroke following Moderna vaccine and Pfizer vaccine, and were among age groups different from the 2022 to 2023 signal. These signals were presented to ACIP in 2024. To further evaluate these signals, VSD performed self-controlled case series analyses for both seasons. These data have not been previously presented. This slide shows the self-controlled case series analysis for the 2022-2023 Pfizer vaccine, including subgroup analyses for people who received the COVID-19 vaccine with or without influenza vaccine on the same day. Age groups are shown by row, and incident rate ratio for both 21 and 42-day risk intervals are shown in the columns on the right. There were no statistically significant increased risk for ischemic stroke for either separate or same-day administration in any of these analyses. Next slide, please. Previous slide, please. Okay, yes, thank you. This slide shows the self-controlled case series analysis for the 2023-2024 season for both the Pfizer and Moderna vaccines. Again, no statistically significant increased risk for ischemic stroke was identified for COVID-19 vaccine, with or without same-day administration of influenza vaccine. FDA also performed a self-controlled case series analysis for the 2023-2024 season among Medicare beneficiaries aged 65 years and older who received COVID-19 vaccine. FDA also did not find evidence for increased risk of ischemic stroke following vaccination with vaccine from any of the manufacturers shown here. In summary, the Vaccine Safety Data Link Rapid Cycle Analysis Surveillance monitored a list of pre-specified adverse events of special interest, including ischemic stroke. The VSD detected statistical signals for ischemic stroke after COVID-19 vaccines during 2022 through 2023 and 2023 through 2024. However, subsequent signal evaluation using self-controlled case series analyses in the VSD and in other data sources have not confirmed an increased risk of ischemic stroke. So thank you for the opportunity to present, and back to you.
Thank you so much. And that was actually a little bit shorter than the assigned time, so I appreciate that. Thank you so much. We are going to move forward actually with the next presentation directly, and we will have Q&As, but we will do that after all the presentations. So please, Dr. El-Dairi and Dr. Cooperwasser.
Yeah, Dr. Cooperwasser will lead off. Charlotte, you're on mute.
My apologies. We'll start that again.
Thank you.
Dr. Wafiq, Algeri, and myself will be summarizing 4 major areas related to terms of reference 6, 7, and 8. Next slide, please. First, for immune changes, literature on both site-specific and non-specific immune effects was reviewed, focusing on the cumulative short and long-term impact of repeated boosting. This is an area where data are still emerging. Second, on biodistribution, the clinical and scientific information was reviewed, both from the literature and from the FDA. Third, frame shifting was tracked given its potential to alter protein products and downstream immune responses. And finally, for impurities, published and unpublished data about residual DNA in existing mRNA products was reviewed. Next slide. There is evidence that COVID vaccination, especially after multiple doses, is associated with a range of immune changes. One of the best documented findings is IgG4 class switching, reported in a seminal study by Arang and colleagues. They showed that individuals receiving Pfizer's BNT162b2 mRNA vaccine developed anti-spike IgG4 antibodies and IgG4 switched memory B cells within 6 months of their second dose, with levels rising further after a third dose. Importantly, these changes were linked to reduced antibody effector function, consistent with IgG4's role in promoting immune tolerance. Other studies have reported the production of anti-idiotype antibodies and persistent alterations in IgG glycosylation patterns. These structural modifications can influence how antibodies interact with immune cells, tipping the balance toward either inflammation or tolerance. Beyond antibody changes, vaccination has also been linked to long-lasting shifts in cytokine profiles, with elevated inflammatory cytokines persisting for months. These immune alterations may contribute to an increased risk of recurrent or persistent infections in some individuals. Finally, work from Akiko Iwasaki's lab at Yale has demonstrated cellular immune changes, including reductions in circulating memory and effector CD4 T cells, alongside increases in TNF-alpha positive CD8 T cells following vaccination. Next slide, please. These and other studies raise questions about the persistence of the immunological changes associated with mRNA vaccination, along with their long-term clinical significance and consequences. And because of the long-term changes in cytokine profiles and T cell ratios observed in vaccinated individuals, more research is needed to evaluate vaccine effects on shaping both innate and adaptive immunity over the long term. Next slide. For biodistribution, Pfizer did not use the actual spike mRNA product in their studies. Instead, they substituted in a luciferase reporter mRNA packaged in the same lipid nanoparticles. This approach allowed them to track where the mRNA traveled in rodents. The studies showed that following intramuscular injection, most of the mRNA remained at the site of injection, but there was also notable levels detected in the liver. Despite the limitations of this approach, which can underestimate low-level or transient distributions to other tissues, it nevertheless showed that the vaccine components do not remain confined to the injection site. Next slide. For Moderna, no dedicated biodistribution study was performed with the COVID mRNA itself. Instead, data was provided from a surrogate product, a CMV mRNA, mRNA 1647, which used the same lipid nanoparticle formulation. In their rat study, after intramuscular injections, high levels of the mRNA were detected at the injection site, but also in multiple organs, such as the draining lymph nodes, spleen, eye, and liver. Lower levels were also found across a wide range of tissues, including the heart, lungs, testes, and brain. Importantly, this study clearly showed that the mRNA can cross the blood-brain barrier. Next slide. Consistent with what is seen in animal studies, the vaccine mRNA and its spike protein have been detected in humans across multiple tissues, including blood, lymph nodes, the heart, and even the brain. These findings make it clear that the mRNA does not remain confined to the injection site. Importantly, persistence has been documented well beyond the initial hours or days, lasting weeks in some tissues, and in certain studies, detectable for many months. Next slide. To summarize the biodistribution data, it's important to note that neither Moderna nor Pfizer used their actual commercial mRNA vaccine products in the preclinical biodistribution studies. Instead, they relied on surrogate construct packaged in same or similar lipid nanoparticles. Second, the results of those studies show that the mRNA and lipid nanoparticles were not confined to the injection site. Systemic distribution was observed with evidence that the mRNA can cross the blood-brain barrier. Consistent with these findings, studies in humans have confirmed that vaccine mRNA can be detected in multiple tissues, including lymph nodes, the heart, the central nervous system, and blood. Finally, persistence is not just short-term. In some reports, mRNA has been detected for weeks to months, and in certain cases, as long as 706 days post-vaccination. Taken together, these data highlight that biodistribution is broad and persistence is longer than initially expected, raising important questions and concerns for ongoing research and safety monitoring. Next slide.
Thank you, Dr. Cooper-Wasser. The work group focused on a couple of other areas that I will describe. The first is ribosomal frame shifting, which is a mechanism used by viruses to express different open reading frames that can help viruses progress infections. The nucleoside modified mRNA with pseudouridine increases frame shifting significantly, up to tenfold. Next slide. And there's evidence that these unintended off-target proteins generate an immune response in humans along with antibody production. The immunogenic or toxic properties of the non-spike proteins is unknown, and the health consequences of prolonged and persistent non-spike protein production have not been studied. Next slide. Another issue I'd like to bring your attention to involves multiple reports of DNA impurities in Pfizer and Moderna mRNA vaccine vials. The most recent report came from Spiker et al., where they looked at 32 vials, including 16 unique vaccine lots, and found evidence of fragmented DNA, plasmid DNA in both Pfizer and Moderna vials. And in all Pfizer vials, they found SV40 enhancer origin of replication that was not detected in any of the Moderna vials. Next slide. So there are some differences between the Pfizer and Moderna mRNA vaccines, principally around the SV40 promoter enhancer origin sequences, as well as the detectable amounts of DNA fragments. I would like to point out that the FDA limit of 10 nanograms was set for naked DNA, not DNA in the presence of lipid nanoparticles that can carry DNA into cells and their nuclei. Next slide. So to summarize the DNA impurities, both the Pfizer and Moderna vaccines have been found to contain DNA that exceeds the FDA limits. Importantly, the DNA impurity limits do not take into account lipid nanoparticles, which carry DNA into cells and nuclei. There are concerns due to known DNA integration and gene activation disruption by SV40 promoter enhancer sequences. Next slide. There has not been a reliable or really any population study in the United States with cancer outcomes after COVID vaccination. But cancers have been reported in mRNA vaccinated individuals in temporal association to immunization. Actually, the number should be 48 case reports that are listed below. Primary cutaneous lymphomas is actually 24. There's a study of 96 cases of pancreatic ductal adenocarcinoma with worse outcomes among those with higher IgG4 levels, which occurs, as Dr. Cooper-Wasser mentioned, with repeated vaccination. There's also a study not listed here with 76 colorectal cancers. It's a case control study where the vaccinated seem to have more mismatch repair deficient cancer. Next slide. There are gaps in our knowledge, including the extent of DNA contamination in current lots, the biodistribution of any contaminating plasmid DNA that can persistently produce spike protein, genomic DNA and integration in tissues or tumors in vaccinated patients, is an area we don't know much about at this point, along with the involved mechanisms. The prevalence of adverse outcomes from impurities versus the extent of contamination is an area that needs more information. We have a gap in our knowledge of the relationship between multiple vaccinations and spike persistence. We do not know enough about the cancer mechanisms, certainly questions about causality. However, there are numerous plausible mechanisms. There are variations in host susceptibilities to adverse outcomes that are emerging for certain other adverse events that are likely relevant to the areas of uncertainty that we are speaking about. So next slide. In summary, there are COVID vaccine safety concerns that stem from unexpected biological activities of mRNA gene therapy platforms, raising questions about potential pathogenic mechanisms and human subjects research protections. We would like to put forth some recommendations, including proactive and modernized safety surveillance programs that involve blood and tissue-based monitoring, epidemiologic studies, AI-driven analysis using reliable standardized data sets, expanded autopsy programs to clarify causality in serious outcomes, programs that systemically evaluate COVID-19 vaccine safety, FDA approval policies calibrated to gene therapy-like risks, importantly, DNA limits that take into account lipid nanoparticles, stronger pharmaceutical accountability, and CDC guidelines ensuring transparent risk disclosure, mitigation strategies, and robust informed consent. Thank you.
Thank you for that. And there is one more presentation from a COVID-19 workgroup member. That is Dr. Bruce Charlton. Thank you.
Hello. Just waiting for my slides.
Please go ahead.
Sure, just waiting for my slides. I don't see them.
We're working on them.
Okay,
They're going
thanks.
to be up in just a second. Thank you.
No, not a problem. There we go. Hello, everyone, and thanks for the opportunity to share some of the research that I'm doing on vaccine-induced myocarditis from the COVID-19 vaccine. I'm Bruce Carlton, a professor of pediatrics in the Faculty of Medicine at the University of British Columbia. Next slide. These are my disclosures. This particular work was funded by a grant to the Global Vaccine Data Network that was provided by the U.S. Centers for Disease Control. I have a number of government funding sources in Canada, and I am listed some past consultancies and also some work I'm doing on COVID-19 vaccination related dysautonomia funded by React-19. Next slide. I've already mentioned the Global Vaccine Data Network, next slide, as a funder. And this is a collaborative network of 32 countries and getting larger. Beyond the genomics work I'm going to present today, they've also will be publishing the largest myocarditis and pericarditis COVID-19 vaccine study to date, as well as, I think, important to note that in that particular study, they also include booster doses. Next slide. So this grant was canceled with 48 hours notice in March, but I had a chance to do some initial work. This is all very preliminary, and I'll talk about next steps at the end. But essentially, these are 50 patients that range in age from 11 to 83 years. You can see their self-reported ancestries. We will do some genetic ancestry on these particular patients as well to understand the generalizability of findings. We're looking at patients who received both Pfizer and Moderna vaccines. And the data over when the myocarditis first occurred is listed by dose. So most of the cases occurred after the second dose. There are some after the third and first doses. I only have, at the time, I only had data on the onset of myocarditis symptoms after vaccination for 30 of these 50 patients, and that was a median of 4 days with an interquartile range of 3 to 26 days. Next slide. So 50 cases were sequenced. We used an exome captured library preparation for the NovaSeq 6000 system, reaching an average depth of 100x. The reads were aligned with the GRCH38 human reference genome, and 49 out of 50 samples passed the quality control process. One sample did not have sufficient quality DNA to proceed. And I specifically looked at variant frequencies that occurred in at least 50% of cases of these 49 cases when the global allele frequency, as noted by ClinVar, a database that provides gene allele frequency information, when the global allele frequency was less than no greater than 15%. So you're going to be seeing genes that actually occur in a very large number of cases compared to what should be occurring. Next slide. So these are the results. There are 18 different genes, and because we're looking at the exome, we're looking at the protein coding region only of the DNA. This allows us to look at some rarer variants, but certainly variants of known significance. And I've highlighted in yellow the 7 variants across 4 different genes that have been previously identified to the development of myocarditis or cardiac inflammation in general. There are 4 Titin variants, which I suppose isn't too surprising given that's a very large gene, but there are 3 others as well. Next slide. And what this slide shows is that of the 30 patients that I had time to onset of myocarditis data at the time of this analysis, it shows the number of patients that are homozygous for these variants. So they have both copies of the variant. And you can see that since this is days after COVID-19 vaccination on the vertical axis, that as you increase the number of homozygous variants, you decrease the number of days after COVID vaccination in which symptoms begin. Now, again, these are very small numbers. I recognize that, but this is an interesting trend. Next slide. So what are these particular genes, these 4 genes and 7 variants? Well, we have LDL receptor-related protein 8, which is a particular variant linked to cardiovascular inflammation and immune response, particularly in coronary artery disease and myocardial infarction. And we had 10 patients homozygous for the risk allele and 19 heterozygous. Next slide. Angiotensin II type 1 receptor is something that's been discussed a lot with COVID-19 in the past. These particular genotypes in this small population of patients were associated with previously with greater than 90% left anterior descending artery stenosis, also associated with MI susceptibility and essential hypertension in other studies. And among these 49 cases, 4 were homozygous and 24 were heterozygous. Next slide. This is just a graphic showing the relationship between these variants and their function in the renin-angiotensin system. And you can see that in the case of AGTR1, that has a enhancing effect to angiotensin II, thereby developing hypertension, vasoconstriction, and cardiac hypertrophy. In the case of LRP8, this it reduces the activity of ApoE, which then results in higher P38 marked pathway activation and resulting cardiac inflammation. Next slide. VKRC1 is highly expressed in the heart. It's well known to be associated with warfarin dosage and vitamin K signaling, also associated with arterial vascular diseases and vessel calcification. 3 homozygous patients, 24 heterozygous. Next slide. Briefly, in this picture, when you block the vitamin K cycle pathway here with these risk haplotypes, you end up with vascular calcification and atherosclerosis. Next slide. Titin, most frequent causes of dilated cardiomyopathy. About 25% of familial and 18% of idiopathic cardiomyopathy are caused by these particular variants. Again, associated with acute myocarditis, with a higher variant prevalence in cases than controls. This is in other work, not in this particular study. We had 3 homozygous for all 4 variants, 2 homozygous for 3, and 21 heterozygous. Next slide. Essentially, titin variants lead to sarcomere insufficiency, and you can follow the pathway there to dilated cardiomyopathy. Next slide. So before this particular grant was canceled in March, the goal was to collect 275 cases of each of the following adverse events in the table on the left side, and then enroll also controls. These would be vaccinated patients without these adverse events, and then do case control genetic analysis, starting with genome-wide studies, and then following up with exomes. The next step after that, of course, is whole genome sequencing, where we can cover even more genes and get better coverage of the genome. Next slide. I'll just say this as a final slide, that genomic studies of drugs have really revolutionized drug therapy. More than 500 FDA-approved drugs have genetic information annotated in the drug labels. And doing the same type of work for vaccine adverse events would serve 2 purposes. First of all, it helps us understand the biological mechanisms underlying the pathophysiology of adverse events. And second, in patients who have risk variants, we can allow for more personalized vaccine schedules. In the case of mRNA vaccines and myocarditis, switching patients to either protein or non-adenoviral vector vaccines, for example, would be one option. thank you for your attention. I'm happy to answer questions at the appropriate time.
Thank you very much. We will have questions and answers, but we're going to move forward with the next presentations before that, and that will be Dr. Srinivasan.
Thank you, John. I'll move now to an economic analysis of the COVID vaccine. I'd like to acknowledge the research team, which includes collaborators from CDC, Wake Forest, and the University of Michigan, who have worked together to contribute to this analysis. There are no conflicts to report. The objectives of this study were to estimate annual population disease burden and healthcare utilization associated with COVID-19 illness and COVID-19 vaccination, including resource utilization, such as outpatient visits and hospitalization, total cases, total costs, death, and quality-adjusted life years, or QALYs, lost, as well as to estimate events averted by COVID-19 vaccination and incremental cost-effectiveness for subgroups by age and risk status. The intervention strategies included in the analysis were vaccination against COVID-19 illness with an updated generic mRNA booster and no updated mRNA booster. That is, vaccination against COVID-19 illness with primary series only or primary series plus current booster. The target population included all U.S. adults stratified by age into 18 to 49 years, 50 to 64, and 65 plus, and risk status, either at high risk for COVID-19 complications or not. Pediatric and adolescent age groups were excluded from the current analysis as there were insufficient data to incorporate these age groups into this phase of the analysis. The time horizon for the analysis is 1 year, with costs and QALYs lost due to long-term sequelae and deaths beyond 1 year accounted for. The analysis uses a societal perspective with a costing year of 2024 and a discount rate of 3%. We used simulation modeling to project costs and health outcomes for each age group. This slide shows a simplified schematic of the simulation model. In the model, an individual has some probability of remaining disease-free or experiencing COVID-19 illness. If they experience COVID-19 illness, they can have an episode of non-hospitalized COVID-19 illness or become hospitalized due to COVID-19. Symptomatic individuals can also incur an outpatient or ED visit. If hospitalized, the severity of illness can require ICU care or ventilation. All individuals who had COVID-19 illness are at risk for long COVID. Hospitalized patients also have probabilities of long-term permanent sequelae or death. As simulated individuals travel through the model, they accumulate costs and loss in quality of life associated with each health state. Also included in the model are adverse events associated with vaccination, including systemic reactions, anaphylaxis, and severe events such as myocarditis. These events are associated with costs and loss in quality of life depending on the severity of the adverse event. Each probability, cost, and quality adjustment is represented by a most likely value and a range of plausible parameter values. Identical cohorts are run through the two submodels, one in which all individuals in the cohort receive a dose of the COVID-19 vaccine, and one in which they do not. The next few slides will briefly present the key inputs into the model. Many epidemiological inputs rely on unpublished data, which best reflect the current evidence base for COVID-19 illness and effectiveness of COVID-19 vaccination. This slide lists the categories of epidemiological inputs and associated data sources. Please note that long COVID is also included. This slide shows actual monthly rates of hospitalization from COVID-net data and is included as an illustration of how hospitalization rates have been changing across seasons. The economic analysis uses data from the 23-24 season, shown in blue. This analysis uses seasonality-adjusted vaccine impact, or SAVI, to implement vaccine effectiveness in the model. Seasonal adjusted vaccine impacts combine monthly rates of vaccine effectiveness and hospitalization to account for timing of vaccination with the seasonality of COVID-19 illness rates, That is, how illness rates vary by month. Costs include direct medical costs associated with the COVID-19 illness or vaccination. Productivity losses associated with illness include lost productive time for paid and unpaid work due to illness. Time costs for the individual being vaccinated are also included. Quality of life adjustments are included for illness events and vaccination-related adverse events. These are included as a decrement to QALYs in the model. The analysis is designed to project disaggregated health and economic outcomes stratified by intervention strategy and by age and risk subgroups, including cases, hospitalizations, deaths, costs, quality adjusted life years, adverse events, and number needed to vaccinate. Incremental cost effectiveness ratios in dollars per QALY gained are calculated, comparing updated COVID-19 dose to no updated COVID-19 dose. This metric measures the additional investment in vaccination or cost savings associated with the change in health benefits and accounts for offsets due to averted illness. Uncertainty analyses, including probabilistic sensitivity analysis, univariate and multi-way sensitivity analyses, and scenario analyses were conducted to explore the robustness of the results to change in input parameters. The next set of slides will review preliminary results from this phase of modeling. It is important to note that this presentation reports preliminary results from an ongoing analysis. This slide shows disaggregated results for projected cases, cases of long COVID, hospitalizations, ICU stays, and deaths stratified by age and risk group. Results are presented for cohorts of 100,000. The blue and orange dark shaded bars show the remaining events with vaccination in non-high risk and high risk groups by age. The light shaded bars show events averted with vaccination. The total height of the bar represents the number of events expected without vaccination. The figures in the top panel show that numbers of cases are relatively similar across age and risk groups. The lower panels demonstrate the substantial variability across age and risk groups for hospitalizations, ICU stays, and deaths, with much higher burden of disease and illness averted by vaccination in over 65. This slide reports incremental cost effectiveness ratios, or ICERs, for each age group using a societal perspective. For all age groups, vaccination requires an additional investment as shown in the incremental costs column and yields additional health benefits as measured in quality adjusted life years. The far right column displays incremental cost effectiveness ratios. These range from $498,000 for non-high risk adults 18 to 49 to $149,000 per quality adjusted life year in non-high risk 65 and older. For high risk adults, the range is $375,000 to $44,000 per quality adjusted life year. This slide shows the results of the probabilistic sensitivity analysis. In this analysis, key input parameters are coded into the model as distributions so that quasi-confidence intervals can be generated for each outcome in the model. These results demonstrate substantial uncertainty associated with incremental cost effectiveness ratios, except for the high risk over 65 age group. This uncertainty reflects the level of evidence available for COVID-19 as a new pathogen. This slide shows number needed to vaccinate to avoid one case, one hospitalization, or one death for each age risk group. Number needed to vaccinate is lower for high risk and older subgroups. This slide shows incremental cost effectiveness ratios using alternative measures of health benefit. Again, here, cost per hospitalization or cost per death averted is lower for higher risk and older age groups. The next few slides present uncertainty analysis as input parameters are varied from their base case values. This tornado diagram displays one-way sensitivity analyses for the most influential parameters in the analysis for the non-high-risk 65 and older age group. The three most influential parameters were seasonality adjusted vaccine impact, probability of hospitalization, and cost of the vaccine dose. Incremental cost effectiveness ratios for this age group are highly sensitive to changes in input parameters. Not shown here are the one-way sensitivity analyses for the other age and risk groups, which show similar results. Results for high-risk 65 and older are most robust to changes in input parameters. The next few slides will provide details of these sensitivity analyses. This slide shows the change in cost effectiveness when varying the probability of hospitalization across lower and upper bounds for all age risk groups. These results show more favorable cost effectiveness ratios across all groups when the probability of hospitalization is set to the upper bound in the far right column and are cost saving in the high risk 65 and older group. The incremental cost effectiveness ratios are less favorable when using the lower bound. Results are highly sensitive to changes in the costs of vaccination. The largest component of the cost of vaccination is the cost of the vaccine dose. A lower cost per dose, as shown on this slide, is associated with substantially lower incremental cost effectiveness ratios. Varying the cost of vaccine dose to $60 per dose would move the incremental cost effectiveness ratio to less than $198,000 per QALY for high risk and non-high risk groups greater than or equal to 50 years, and would be cost saving for the high risk 65 and older group. Few cost effectiveness analyses include wastage as a separate cost in the analysis. When it is included, this is often in the case of a new vaccine where the price is unknown. Conventional assumption is that any costs associated with wastage are reflected in the price per dose if returns are allowed, or the administration fee if provider bears the cost of unused doses. Scenario analysis on price per dose yields insights if wastage is not adequately captured by base case assumptions. This analysis includes limitations. Unpublished data has been used to derive key parameters in the model: vaccine effectiveness, symptomatic illness, probabilities of hospitalization, and critical illness. Data sources vary in representativeness and generalizability. VE estimates were derived from a single prior season's data. Few COVID-19 seasons are available to estimate seasonality. The evidence base for long COVID is especially scarce, and the model does not include reduced transmission, which is a conservative approach. In summary, vaccination averts substantial morbidity and mortality in all age and risk groups as demonstrated through estimated disaggregated outcomes. There is substantial variation in impact by age and risk status. Overall economic favorability has declined compared to estimates from earlier seasons due to declining burden of illness. Incremental cost effectiveness ratios for 65 plus age groups are robust to changes in parameter inputs across plausible ranges. Incremental cost effectiveness ratios for 18 to 49 years and 50 to 64 year age groups are sensitive to changes in parameter inputs and favorable only under certain conditions for high risk 50 to 64 year age groups.
Thank you very much. And that also came in at less than the assigned time, so I really appreciate that. Thank you so much. We have three short statements from the COVID-19 vaccine manufacturers. And the first one is from Sanofi. Dr. Scharf, please. Do we have Dr. Scharf on the line?
Hello, can you hear me?
Yes, thank you. Go ahead.
Hello, can you hear me?
Yes, we can hear you. So please go ahead.
Okay. Thank you for this opportunity to speak today on behalf of Sanofi and our partner Novavax. My name is Dr. Katie Scharf. I am a medical director for Sanofi and a practicing infectious disease physician. During the pandemic, I was at the front lines as an infectious disease physician treating patients with COVID-19. Additionally, I provided clinical oversight for the state of Oregon's COVID-19 mass vaccination site, which administered over 500,000 doses of COVID-19 vaccines. Nuvaxovid, COVID-19 vaccine adjuvanted, is a recombinant protein COVID-19 vaccine, which is based on a well-established technology platform. It is the only non-mRNA protein-based vaccine available in the United States, providing Americans an important tool to protect themselves against COVID and ensure that they have choice in doing so. In May, the FDA fully licensed Nuvaxovid based on pivotal phase 3 clinical trial data that showed Nuvaxovid was safe and effective for the prevention of COVID-19. The product is indicated for adults 65 years and older and individuals ages 12 through 64 at higher risk for severe outcomes from COVID-19. The vaccine has also been fully approved by other regulatory authorities around the globe, including the European Medicines Agency. The ongoing safety and effectiveness of Nuvaxovid is our utmost priority. We continue to generate and share clinical and real-world evidence to support the ongoing use of Nuvaxovid. This data is shared with the scientific community, regulatory authorities, and the public in a variety of forums. We have substantial post-marketing safety experience with Nuvaxovid, with a database that includes over 5 million doses administered globally. There were no new safety signals identified for the 2023-24 or 2024-25 formula of Nuvaxovid. As with all our products, we continue to monitor and report to regulatory authorities any new or existing safety signals. Starting this fall, Sanofi is responsible for the commercialization of Nuvaxovid. The product has a 6-month shelf life and has already begun shipping to healthcare providers and local retailers in the United States. Sanofi looks forward to expanding awareness and access to Nuvaxovid to allow eligible individuals the availability of the nation's only protein-based non-mRNA COVID-19 vaccine this fall. Thank you for the opportunity to speak today.
Thank you so much. And Dr. Sedia, Moderna, please.
Hello, checking that you can hear me.
We can hear you, thank you.
Excellent, thank you. Well, thank you for the opportunity to speak. I'm Dr. Bishoy Riscala at Moderna Medical Affairs. The COVID-19 pandemic was an unprecedented challenge. Moderna partnered with the US government through Operation Warp Speed to deliver one of the first authorized vaccines. Since then, we have worked with health authorities worldwide to ensure timely access to updated vaccines as variants emerged. Real-world evaluations in millions of US recipients show that updated vaccination provides additional protection, especially for adults 65 years and older and those with risk factors at increased risk of serious outcomes. Those findings were confirmed this past winter by CDC and by governments including Canada, the UK, and across Europe. We monitor safety through clinical trials, post-authorization studies, and global pharmacovigilance. We review every safety signal that comes to our attention. Our product labels across 90 countries reflect all signals that have been verified. FDA and health authorities, including Canada, UK, Europe, have recently approved the updated 25-26 booster, concluding benefits exceed risks for those 65 and older and those younger with risk factors. Individual benefit risk has been clearly established by the competent health authorities. We note that one of today's presentations includes assertions not aligned with the broader scientific evidence. Some conclusions extend beyond what reference studies support or contradicted by careful reading. Others appear based on isolated case reports that are presented without relevant clinical context or omit a larger body of published evidence to the contrary. Claims of long-term persistence of vaccine-derived spike or mRNA are refuted by well-controlled biodistribution studies conducted to regulatory standards globally, using licensed product and shared with FDA showing no evidence of long-term persistence. The cited studies cannot distinguish spike from viral infection from that of vaccination. One even reports higher spike levels in unvaccinated controls. Residual DNA is also mischaracterized. This is a tightly regulated quality attribute across vaccines and medicines using assays validated to FDA standards. Every lot is tested by Moderna and independently reviewed by FDA prior to release. FDA has stated that animal studies and extensive real-world monitoring after more than 1 billion doses show no sign of genotoxicity. The German Health Authority has noted that the non-validated methods described in reference studies overestimate DNA by counting RNA as DNA. Our commitment is straightforward: transparency and rigorous assessment of the totality of evidence. We will continue publishing data using validated methods, and we will work with regulators to examine any potential safety signal. Your decision today is important to preserve choice and accessibility of FDA-approved effective vaccines. Americans should have the right to choose protection if they wish. The weight of evidence supports maintaining that access. Thank you.
Thank you very much. And I think I have to correct myself. I believe that was Dr. Riscala and not Dr. Sedya, as I said. So apologies for that. The next one we have Dr. Paul Ballmer, and I think the name will show differently, but I believe it's Dr. Ballmer that will be speaking for Pfizer.
Hi, can I do a sound check? Can you hear me?
We can hear you very well. Thank you.
Thank you. Good morning. My name is Dr. Paul Ballmer, and I'm the US Vaccines Medical Affairs Lead at Pfizer. On behalf of our teams at Pfizer and BioNTech, thank you for the presentations today. I also thank the other manufacturers for the statements that were made, and I will not be repeating any of the comments from those statements. I also want to thank the committee for the opportunity to make this statement. COVID-19 has transitioned from a pandemic to an endemic disease. Even so, COVID-19 disease still hospitalizes hundreds of thousands of Americans and is responsible for the death of thousands every year. Pfizer and BioNTech remain deeply committed to making safe and effective vaccines that help protect lives in the US and around the world. The Pfizer-BioNTech COVID-19 vaccine has been reviewed by multiple regulatory authorities, including the FDA, and has met all safety and quality control guidelines. Pfizer's safety systems work in concert with US government safety monitoring. We report information gathered to the appropriate governmental channels and carry out specific scientific studies under the approval of FDA. In addition to routinely reviewing all published scientific literature for safety concerns, we are conducting many studies that use real-world data from millions of people to continue to assess the safety of our COVID-19 vaccines. At Pfizer, we carefully review every adverse event reported to us and ensure they are reported to VAERS. VAERS is an early warning system. However, it cannot assess causation. As such, FDA and CDC use multiple additional safety systems to understand causation. These were enhanced during the pandemic to include COVID-19 pregnancy registries and vSafe real-time user reporting. Each of these monitoring tools and surveillance systems have their own strengths and weaknesses, but together they build a safety monitoring net that enables identification and investigation of even rare safety signals. Since the COVID-19 vaccine was approved in 2020, assessments conducted along with regulatory bodies across the world show that the benefits of COVID-19 mRNA vaccines continue to outweigh the risks. It's important to consider any potential risk in the context of the demonstrated benefits of vaccination. In the past year alone, COVID-19 vaccines prevented somewhere between 68,000 to 100,000 hospitalizations, averted 13,000 to 18,000 intensive care unit stays, and saved 5 to almost 7,000 lives in the US. In summary, Pfizer and BioNTech remain steadfast in our dedication to vaccine safety, quality, and effectiveness through constant safety monitoring and ongoing research. With 5 billion doses distributed to date globally and continued approval by regulatory agencies in 83 countries, our vaccines are among the most extensively monitored products licensed in the world, helping prevent hospitalizations and saving lives. Thank you.
Thank you so much for that. And we will now move on to questions and answers. And I ask you to say that you can ask questions to any of the presenters this morning. And also for time perspectives, if I ask each one to ask all the questions you have, and then we'll go on for the next one without getting like a second time, so we can go through and have everybody have a chance to ask questions and answers, including the liaison members that we have on the phone. But as always, we are obliged to first have questions and comments from the voting members and the ex officio members. And we do have a list here. And the first one is Dr. Cody Meissner, please.
Thank you, Dr. Kaldorf. First, let me say that this has been absolutely an amazing presentation by everyone this morning. It was a little bit like trying to drink from a fire hose. So much information that's so important. And I think we could spend going over each presentation a lot of time. So let me, as Dr. Kaldorf has requested, I will confine my comments. But first of all, I want to thank the CDC. I want to thank Dr. Levy and Dr. Kaldorf for putting this extraordinary presentation together. I also thank the members of the work group, and especially those members of the work group who are consultants. It was an absolutely fascinating morning. So I'm going to, I have so many questions, but I'm going to confine my questions to the first presentation by Dr. Srinivasan. And I apologize for mispronouncing it. I'll call you Dr. S. I think the question that I had is, as was pointed out by Dr. Malone, there's nothing unique about a COVID-19 respiratory viral infection. You can't differentiate COVID-19 from RSV from influenza. And you addressed one of the critical problems that we've all had, that is how many people were hospitalized with COVID and how many people were hospitalized because of, who had disease. And I think you said there were 2 or 3 physicians who arbitrated that decision. So the first question I want to ask is, were those CDC docs, or were those docs at the hospital? Who was it that arbitrated that? Number one. And number two, the state of Massachusetts, where I am, addressed this issue early on in the pandemic, and it was demonstrated that only about a third of patients who were hospitalized with what was called COVID were actually in the hospital because of COVID. They were otherwise just essentially colonized. And what the state of Massachusetts did was to break that down as to who was getting dexamethasone. They used that as a kind of a surrogate marker, because if you were hospitalized with a SARS-CoV-2 infection, just about everybody realizes if you're sick enough to get into the hospital with mild or moderate disease, then dexamethasone is one way to kind of a poor man's distinction between colonization and disease. So it's such an important issue, and I wonder, just because there was a arbitration, someone had a positive PCR, which is a very reliable assay. I'd like to know a little bit about more about how they were classified as a COVID illness. And then the last question I'm going to ask, because I don't want to be unreasonable, is about the data regarding vaccination of pregnant women and the difference in hospitalization with their infants. I guess I'm inherently skeptical of that. I think that a newborn who's born to a mother who's COVID positive is going to have a COVID test, whether the child is hospitalized or not. So can you tell us a little bit more about the reasons those children were hospitalized, and what was it that led you to believe that the hospitalization of those newborns was because of COVID-19? What symptoms did they have that differentiated them from other children? Yeah, RSV, or from the children who were positive but not admitted. So thanks once again for everybody's presentation, and just, it was fantastic, and I'll stop there.
Just a very quick comment, Dr. Meissner. Interestingly enough, you mentioned the fraction 30%. I think the data of the CDC, when analyzed, if I'm not mistaken, in a paper that was shared with us, the fraction of patients that had a COVID diagnosis on their principal discharge diagnosis was 30%. Maybe it's a coincidence, but somehow coincides somewhat with the numbers that you state from Massachusetts, and I think other places that did these studies showed similar numbers in a range between 50 to 30%. So that I just find it interesting. So.
Thank you, Dr. Betzef. And because this virus characteristically colonizes the pharynx and will give a positive PCR assay, even in the absence of symptoms. So it's a very important question, and I appreciate the CDC's willingness to discuss that a little further. Thank you.
Thank you.
I agree with your assessment and praise for this presentation. That praise goes 100% to Dr. Ratzef Levi and a member of his working group, as well as, of course, to the presenters. I would like now to hear a answer from Dr. Srinivasan.
Yeah, and let me open this up to the subject matter. There's a number of questions here to answer. So let me open this up to the subject matter experts at CDC on the line to address the various questions that Dr. Meissner has raised. Go ahead.
Hi, can you hear me?
Yes, we can.
Hi, this is Chris Taylor, and thank you for your questions, Dr. Meissner. I'll address your second one first regarding the infants. I don't know if we can, probably isn't time to bring up the flow chart, but I wanted to make the point that for infants, for our reason for admission algorithm, we exclude infants who are hospitalized at the time of birth. So that subset of patients we do not include. We exclude them. If it's a hospitalization at the time of birth, they're excluded, as we would exclude a woman presenting for labor and delivery, or someone who is presenting with an injury related to a car crash or a scheduled surgical procedure.
Understood. Thank you.
Mm-hmm. With regard to your second question, and I'll reiterate the point, I think what's really important to remember is that determining why someone is hospitalized is very difficult, and our tool is the medical record. We are not the clinicians on the team, and so we make the best decisions we can with the data that are available to us and with our valued colleagues in the state and local health departments. And we know that ICD-10-CM codes are an imperfect data source. In a peer-reviewed publication from our program, we do cite the Massachusetts study looking at the systemic steroid use. If you look at just steroid use or just other medications that are recommended for the treatment of severe COVID, if you look at reason for admission, if you look at discharge diagnosis, they're all going to tell a different story. What we've tried to do is identify the cases that we believe are most likely due to COVID hospitalization, hospitalizations where COVID-19 has a significant impact on the care, on the reason for admission, and also balances the needs of the data that are available to us with the timeliness in which it is required. So I do appreciate the question. I guess what I want to say is that we believe that what we are doing is not perfect, and I think ICD codes are not perfect. Using treatment guidelines is not always perfect because every patient is different. And we try to take that into account. And we hope you appreciate the effort that we put into this algorithm that has been in use for several years now.
Thank you, Dr. Taylor. I do appreciate the enormity of the task that you have. And
thank you.
You've done an admirable job at trying to address it. My only concern is that's the basis on which many people are advocating vaccination of pregnant women. And I don't think there's acknowledgement that this is a very uncertain parameter. And I think that should be more widely noted.
Hi, this is the room. Thank you very much for that question. I think the important thing for COVIDNet is that we collect all hospitalizations among people living in certain catchment areas, which means we count every single hospitalization on a population level for those counties that are included in our surveillance system. And as you talked about, we do a very thorough process to determine which hospitalizations are for COVID and due to COVID. And those are the data that we show when we show that, 1 in 5 infants under 6 months who are hospitalized with COVID end up in the ICU, when we show that 1 in 4 children between the age of 0 and 17 end up in the ICU, when we have published data that shows up to 40% of children hospitalized with COVID-19 due to COVID-19 have a severe outcome, including death, ICU admission, or receipt of mechanical ventilation. And in terms of the infants less than 6 months, as Dr. Taylor said, we exclude the infants who are hospitalized at birth. So the infants that are included in COVIDNet are only those infants who come in to the hospital and require hospitalization. The tests that we use to determine, we actually don't do that. The hospitals determine which people are tested for COVID, and we simply count them. And it's really important to note that the infants under 6 months have hospitalization rates that are equivalent to the adults who are 65 to 74. That's what our national surveillance demonstrates, and that's demonstrated in many other systems in the United States. And so, thank you very much.
Well, thank you. I'm not sure who that was. Who was that just talking?
Hi, this is Dr. Patton. I'm the team lead for this team that oversees the RESPNet surveillance system.
Thank you, Dr. Patton. And I don't want to prolong this conversation, but I'm looking at the chart that I printed out on Wednesday from the CDC, and it says weekly rates of COVID-19 associated hospitalizations by season, okay? And since February, the hospitalization rate per 100,000 has been less than 0.8.
Hi, thank you. Those are weekly rates. And so what we use to look at overall rates for the year are cumulative rates. So we look at the total number of infants who are hospitalized over a year divided by the population of people in those catchment areas. And those are the data that were shown on the slides today. If you look at the bar chart, I think it's challenging for us to pull up slides at this point. But if you look at the bar chart that shows the cumulative rates for this past year, you can see the cumulative the cumulative hospitalization rates for infants less than 6 months, infants 6 to 11 months, and then by age group. And so weekly rates definitely vary based on, circulation of the SARS-CoV-2 virus. And that's what we demonstrate on the website. Actually, if you go to the other section, there is also a section where you can see cumulative rates based on the selections that you'd like to look at.
Yes, but since October of last year, the hospitalization rate for children under 18 years of age has been less than 1 per 1,000. So I don't think we should make our decisions about future vaccines based on what's an accumulative data. The virus is changing. Immunity is changing because of vaccines and because of immunization. I think it should be based on more current data. And the current data is it's less than 0.4 per 100,000.
Yes, thank you for that question. What's important to note is that when you group in the older children who are hospitalized at lower rates into the overall cumulative hospitalization rates, it does look like the overall rates for all children are low because we know those older children are not being hospitalized. What's really important when you're looking at epidemiology and how different diseases affect different populations is to look at population-specific rates of how that disease is affecting that specific population. That's the really the great thing about COVIDnet is that we can really drill down into which groups are being most impacted by COVID hospitalizations. So if you look, you can see that infants under 6 months have the highest rates among all groups of children. Infants age 6 to 11 months are the next highest. And infants less than 6 months have a rate of 223 per 100,000 population. And so, that's really what the purpose of these surveillance systems is to be able to look at the impact of these diseases on different groups. Thank you.
Thank you for that. And I am quite familiar with the point that you're making, and it's a very true and valid point. But I don't have the precise numbers for those under 6 months of age, but I still think that if you look at current times, it's not that high. And I think that there is an overemphasis on the amount of disease relative to what's happening now. The virus is becoming less invasive. It causes less severe disease, and everybody has immunity from an infection and or vaccination. So I think that has to be taken into consideration. The question that I have for you, if Dr. Kuldorf doesn't cut me off here, and it's the question I asked last time, at what point does the low uptake of a vaccine influence CDC recommendations? If less than 20%, for example, are accepting a vaccine, shouldn't that be reflected in your guidance? It's almost like prohibition. No one was supposed to drink alcohol, but people did. Why do you keep saying this when, because I'm worried it interrupts credibility for the CDC. If you make a recommendation that people are simply not going to follow, I don't think that's wise.
Thanks. Just one clarification on the cumulative rate. The cumulative rate is per season. So when we talk about a cumulative rate, that's for this most recent year, not over the course of the entire 5 years. Thank you.
Thank you very much for your efforts.
Thank you for that. And next on the list, we have Dr. Levi. Okay, so then we have Dr. Griffin.
Thank you. Actually, I did have a comment. Thank you, Dr. Meisner, for bringing up this issue because it does stem into my world of OBGYN. The comment on that presentation for the 6-month-olds or less than 6-month-olds, the comment was made that there is no approved vaccination for under 6 months of age. Therefore, the mothers should get vaccinated. So this is a wonderful example of how confounding variables that are not unveiled can bias the representation of the data. So it wasn't described that there were confounders that were not discussed, but a statement was made that pregnant women should be vaccinated. So I'll present some scenarios, for example, that could be investigated perhaps for a future study. For example, on slide 28, it was shown here in the presentation that more than 3 comorbidities have a statistically significant difference in COVID-19 hospitalizations. So we can ask, how many comorbidities did the pregnant mothers have? Did they have COVID? Were they perhaps infected, or were they vaccinated do we know if they were vaccinated during their pregnancy, and then their babies perhaps had been more susceptible because of altered immunogenicity to succumb to COVID diagnosis? Were the babies preemies? Back to the mother, preeclampsia, hypertension, diabetes, obesity, those are the most common comorbidities in women, and those rates are skyrocketing in our childbearing age population now in women. So just some thoughts. But if I can move on to my questions now.
Please do.
Thank you. Regarding the biodistribution studies, there's a lot that was said here that I was not aware of. My first question is, which regulatory bodies have approved Pfizer and Moderna to not use their final end product to study if their product does not stay in the arm, as was stated, and actually travel to the brain and other organs? And if I may, I'll ask a follow-up question, so perhaps all of them can be answered. Is Pfizer and Moderna, were they aware of the plasmid DNA and SV40 contamination? Did they try to replicate that study or initiate any population studies to test vaccine recipients, the recipients of their products? Dr. Carlton, why was your study canceled in 48 hours? And last safety question was to the CDC presenter, just discussion on the VAERS reporting that came from CDC. Any comment on that? Thank you. I'll be happy to repeat any of those. Dr. Carlton, if you would like to go first.
Sure. I don't know why the grant was canceled. I understand that HHS has said the period of performance ended on March 25th. The grant was several years long, involves international surveillance, as I mentioned, the network, and that's the information I was given by the principal investigators.
Okay, thank you. And then to Pfizer and Moderna regarding the biodistribution studies.
So I'm not sure if they're online, the other two speakers.
Can I ask
oh,
you
so
later?
they are online. So I think, so they are online. So hopefully they can.
They should be online, I think.
I can re-ask later.
Who is the question addressed to? Is it to the working group folks or to the actual representatives from the companies?
Actual representative from the companies.
Oh.
Yes, hi, can you hear me?
Yes.
Yes, hi, this is Darren Edwards, program lead for COVID vaccines at Moderna. We have conducted biodistribution studies to assess not only the persistence of our drug product, which is our mRNA and our LNP, but also the spike protein. We have submitted those studies to the FDA, and what those studies demonstrate is that both the LNP, the mRNA, and the spike protein does primarily localize to the injection site and the draining lymph node with some detection in other tissues and organs, but that does clear very rapidly post-injection, with no detection of spike protein more than 14 days after injection in those studies.
And was it the final end product that was used in those biodistribution studies?
It was commercially representative material that was used in those studies, correct?
What does that mean, commercially representative? I don't know what that means. Does that mean something different or
No, it's the same manufacturing,
akin? Not the exact same thing?
same manufacturing process used.
Okay, I was just wondering, because this is novel to me, the mRNA itself, is it the exact same mRNA that was used in the vaccination product that I received, for example?
Yes, yes, it is.
Okay, thank you.
So this is a representative from Pfizer. Our biodistribution studies were done in concert and consultation with the FDA. And we did use a luciferase-based product that was manufactured the same way as our drug substance and our drug product, our LNP itself.
Can I follow up on that as a person who developed that assay and used it first in tissue and also developed the various sub-methods for analysis? You appear to have used the least sensitive method available, that being whole body imaging using a VIM camera, rather than the most sensitive method, which is individual tissue dissection, lysis, and counting an illuminameter. Am I incorrect in that? And furthermore, the data that were submitted to the FDA were edited. They were edited relative to data that was submitted to other agencies. The actual images were edited. Can you comment on that, please?
So Pfizer does not have a further comment other than we did work in close consultation with the FDA on all of our biodistribution studies that were approved for our licensed product.
Fascinating.
Dr. Griffin?
Detection is Moderna for detection of the, in the study where we assessed the COVID vaccine, the biodistribution of the COVID vaccine, we used detection methods specific to the spike. They were not fluorometric methods.
Dr. Griffin, did you have more
One
questions?
question related to this that I didn't think I heard the answer to was whether or not the DNA impurities were measured by the companies.
Yeah, and I was wondering the same
Yes,
thing.
sorry, this is Darren Edwards with Moderna. For every lot, part of our release testing is detection of DNA in each lot. We use industry standard methods to perform these assessments that is specific to DNA and does not detect RNA, which is a flaw and a problem with some of the other methods cited.
Yes, hi, this is Carrie Sweeney, head of analytical for vaccines. We follow on with what Moderna is saying, that we did measure residual DNA within our product, and our assay was validated to be specific for residual DNA and not RNA within the product.
Could I follow up on that question, please? Again, Dr. Malone, the thresholds that were used to establish that you were within allowed parameters are those that the FDA determined as acceptable for naked DNA. Is that true or false? I'm sorry, that was directed at the industry representatives. Were the thresholds used to determine lot release for DNA contamination, those that were developed for naked DNA, or were they in some way reflective of the added delivery efficiency of your particular lipid nanoparticle formulation? Over.
Can we have a response from Dr. Ballmer at Pfizer?
So the threshold used for our residual DNA test, we're following the approved WHO guidelines for residual DNA impurities within a vaccine product.
In other words, those were the thresholds for lot release that were established for naked DNA by the FDA. True or false?
And can you state your name also?
This is Carrie Sweeney Efren from Pfizer Analytical Vaccines, head of analytical. The WHO guidelines we followed were approved for residual DNA within vaccine products.
Right. So you refused to answer the question.
Do we have a response from Moderna on the same question?
Yes, hi, this is Darren Edwards. The thresholds were developed for our product.
I'm sorry. Did I just understand you to say that alternative thresholds for lot release were developed based on integration studies, which is the gold standard with naked DNA that the FDA applied? You did integration studies for DNA fragments using your delivery formulation. Is that true?
So all of the safety data is based on our control of these thresholds. That's fundamental to how our products are assessed. Therefore, the product thresholds are for our specific product.
Yeah, once again, I'm not understanding.
Can you state your name, please?
I'm sorry, go ahead.
Can you state the person who has responded? Can you state your name and company?
Yes, this was that response came from Darren Edwards at Moderna.
Thank you.
Can I?
So I think, Dr. Griffin, if you had more questions or
It'll
was
just
everything
finish off
responded to?
this topic, just because I can't keep up with Dr. Malone's brain. And this is where the rubber meets the road for OBGYNs, because I was asked, does this end up in breast milk? So there is a study, and of course, we're all interested in conflicts of interest. The authors here did have grants from NIH, and they showed there was detection of messenger mRNA COVID-19 vaccines in human breast milk. This is Hannah et al. And I don't have the year exactly, but obviously it's recent. The other one is this going to my baby is the other question. This study has, I cannot access the full article. It says, so I do not know the conflict of interest, but it is from the American Journal of Obstetrics and Gynecology, transplacental transmission of the COVID-19 vaccine messenger RNA, evidence from placental, maternal, and cord blood analyses post-vaccination. And then finally, there was a study, no conflicts of interest here, showing this one was intracellular. So this is showing reverse transcription. So for the media, reverse transcription is basically what happens normally in our cells is we transcribe our DNA to RNA, which then makes protein. If you go backwards, which we were told was not supposed to happen, you get reverse transcription. So intracellular reverse transcription of Pfizer BioNTech COVID-19 mRNA vaccine, BNT162b2, in vitro. So that means not studied on humans, thank goodness, outside of humans, but it reverse transcribed into human liver cell line. So this is concerning because then it's that's reverse transcription into our DNA, but then we have not even started talking about epigenetic concerns. Epigenetic concerns come into play when other genes are turned on or off. So one last paper I'll reference here, Erdogan et al., no conflicts of interest. They showed prenatal exposure to COVID-19. Now, this is a rat study. COVID-19 mRNA vaccine induces autism-like behaviors in male neonatal rats. So these are the questions that parents are asking. So I'm just bringing this to the table because there are studies that are being done to suggest this. So just coming to the table to pose these questions and have hopefully industry and regulatory minds answer the questions for us. Thank you.
And who do you want the industry to respond on? Dr. Griffin? Do you want the industry to respond or somebody else?
Sure. Any and all.
But who would you want to respond? It's you to decide.
Pfizer, Moderna, whoever else we have. Sanofi.
Okay, so can we have a response from Pfizer first?
Hi, this is Kayvon Majared from Pfizer. I'm the research and scientific lead for COVID-19 vaccine franchise. So from the standpoint of biological plausibility, RNA cannot reverse transcribe the DNA and transport from the cytoplasm, the nucleus, to the nucleus and then integrate. It requires a set of molecules and enzymes that don't exist in humans and are largely reserved for retroviruses.
And Moderna?
Yeah, so Bishoy from Moderna. I'd like to add to Pfizer's statement, we agree, but also like to raise the FDA's CIP's letter that was addressed in 2023. Through evaluation of hundreds of millions of individuals, there was no indication of any indication of genotoxicity.
Thank you. And we do have more people on the list. I have tried to run a tight ship here, but there's one thing I'm not going to deny you, and that is the lunch break. So, and on the schedule, it's only 20 minutes. I'm not going to shorten it. So we will now do a lunch break, and we will resume here at 12:20. Thank you very much.
Problem with this camera view is that it shows both of our bald spots. This side. No, I'm well, we talked about infectious disease.
We are continuing the Q&A session. And the next person on the list here is Dr. Milon. So please go ahead.
As a physician that takes care of children, I often have, and people talk about the ethics of whether this is appropriate, but often parents will ask me, well, what would you do if it was your child? And so I thought what's worthy to be brought up, and I thank Dr. Meisner for sort of addressing this issue as well. But when we're looking at hesitancy and on what CDC might recommend, what we might recommend as a committee, and you look at healthcare providers, where the uptake is currently around 10%. I think that's very, I think that's very telling. Excuse me. So that's one thing I wanted to bring up. The other thing I wanted to bring up and thank Dr. Carlton for bringing this issue up in terms of how do we get better at individualizing care. And I thought specifically even within vaccines, but he brought up a very important issue that I'm seeing dramatic increases in my care of children, specifically that are coming to a pediatric cardiologist, and that is dysautonomia, or dysregulation between the autonomic nervous system and the body. So I think that these are all very important things to consider this disruption that has happened in our community. The other thing, I know a lot of people are gone, but I will bring up as a question. When we're talking about hospitalization of children, that is often a soft call. Dr. Pagano and I were talking about this as an ER physician, as a pediatrician. We often find ourselves in situations where we will admit a kid who, let's say, has RSV or COVID, and we really do it more for an observation than as opposed to they needed to be in. And there are many factors involved, even how tired the parent is. Have they been up all night? This child needs to be observed closely. So I would ask, sir, when you looked at hospitalizations, did you have length of stay in that, or is it just positive hospitalization, negative hospitalization?
Thank you. Let me ask if someone in the subject matter expert room has the details on whether or not we have length of stay with these admissions. Go ahead, Dr. Taylor.
We do collect, thank you. This is Dr. Taylor. We do collect length of stay. I don't think I have the statistics at hand by age group, but it's including anyone who meets the case definition and then is hospitalized. But it excludes anything that would be classified as an observation.
Well, I mean, we call them observation, but in order to be an observation, it usually has to be less than 24 hours, and we have to call it. But often what we'll do is we'll have a kid spend the night or a baby spend the night, and they might spend more than 24 hours. But so I think that is something, I appreciate all the work that has gone on to do this, but that is some subtleties that don't always give the clear picture. The other thing I wanted to bring up is, and I think this goes to the hesitancy issue, is there was sort of a new definition that you looked at the vaccine as of, in terms of its effectiveness, but dismissed the issue of whether that it prevented infection. And I didn't see any data on that. And considering what the Cleveland Clinic study showed with over 50,000 healthcare workers, I would wonder if you could comment on that. And the other thing is, when you talked about vaccine effectiveness, did you come up with those prospectively, or was that retrospective, that we're going to show these data where the vaccine is effective retrospectively as opposed to prospectively?
So I'll let the SME room weigh in as well. The issue with the cases versus hospitalization is that cases, of course, with all the testing at home, it's impossible to capture the universe of testing, which was possible previously because, of course, all the testing had to be done in a healthcare facility. But to your other questions, let me let the SME room weigh in here as well.
Hi, this is the SME room. This is Ruth Gillis. So we have previously shown data on vaccine effectiveness against SARS-CoV-2 infection through pharmacy testing. But to the point just raised, there's so much home testing at this point and non-testing that people are not going to pharmacies to get tested. And so those data are no longer adequate to answer a question about vaccine effectiveness specifically against infection. Likewise, in sort of an outpatient setting, people are not generally going to the doctor and getting a COVID test. And so those data aren't captured in a way that we can study VE specifically for infection. And so instead, what we do is we look at emergency department and urgent care VE, as well as hospitalization, vaccine effectiveness against severe disease, which are really the outcomes that respiratory virus vaccines are meant to protect against. And so what we've seen over time is that our VE against infection, when we could measure it, was very similar to what we would expect for other respiratory vaccines, such as flu. And likewise, VE against hospitalization and more severe disease has also been very similar over time to what we would see for flu.
Thank you. One of the reasons I brought that out is because a few years ago, even coming from the CDC, where if you get the vaccine, you won't get COVID. And so early studies that were done is that you didn't even test people with COVID-like illnesses if they were vaccinated. You only tested the unvaccinated because the assumption was in the medical community that it prevented infection. But I think all of us know that it's very hard to prevent a respiratory infection with an injectable vaccine because of the lack of IgA immunity. One last thing, before medicine career, I had a PhD in pharmacology. And I guess I'm shocked at the lack of pharmacological rigor in dosing, dose timing, dose accumulation, how long that dose lasts, and what are the pharmacokinetics of a biologic making a biologic. And so when the question is asked of, okay, so as a cardiologist, I see the spike protein as cardiotoxic. I want to know how long that a biologic has made a biologic, and how long it's going to last. Oh, it goes away quickly. Then we have the recent Yale study that showed femtomoles of spike protein basically until they stopped the assay. So my comment is I am really confused about the pharmacologic rigor for this product before it was released. And now with evidence of contamination, why is this not pulled off like any other biologic or medicine that is found to have contamination?
Is response to that?
That would be a question for the manufacturers or FDA.
Or FDA. Tracy question.
Yeah.
Dr. Hög?
Yes. Hey, can you hear me? Tracy Beth Hogue from the FDA.
Yes.
So I will say that a lot some of the information is proprietary information, and I will say though the information that we have been provided by Pfizer and Moderna and what was shared with me, what they provided to the FDA was within the regulatory limits, I will also acknowledge that, you know, this is something we take very seriously, and I want to sincerely thank the independent researchers, many of whom I know, who have brought this issue to the public's attention. And at the FDA, we take the public's safety and, you know, the safety of these products incredibly seriously. And I just want to give you all that message that this is not something that is being ignored. And I can only, you know, provide with you the information that I have been given about what the sponsors provided us regarding the DNA levels in their products. And so that I think that I'm going to stop with that.
Dr. Hogue.
Do we have a comment from Pfizer or Moderna? And please state name and company.
Can I ask another quick question of Dr. Hogue?
Please do.
Dr. Hogue, are there any plans for a post-production independent evaluation by the FDA?
So I'll say that is something that's being discussed, and we want to communicate that we take this issue very seriously, and thank everyone who has brought this to our attention.
Do we have a comment from Pfizer or Moderna? Okay, so we're going to continue. We have a list here, so we're going to continue now with Dr. Pollock.
Raymond Pollock. This would be a question for both the CDC and the drug manufacturers. I dare say in the room, the vast majority of people here who have had vaccination against COVID assume they're immune. And that is not a common thought amongst the general population. Vaccination equals immunity. But actually, what we've learned from influenza virus vaccines is that may not be the case. And the elephant in the room today, from my perspective, is that we've heard nothing about the production of neutralizing antibody following a course of COVID vaccinations or following a booster of the COVID vaccine. Everybody in this room, I think, has heard of somebody who's, quote, had the vaccine and then I got COVID, or I had the flu injection and then I got flu. And they question the efficacy and the rationale in giving vaccines if, after all, they weren't protected in the first place. Maybe they weren't protected because they were in a high-risk group, immunocompromised, over 65, inability to make antibody. But I think we need to hear from the CDC and the manufacturers what percentage of patients actually fail to make antibody in response to the vaccine, because there the risk-benefit ratio may not be worth it. And it also contributes to vaccine hesitancy. Well, I heard my neighbor got the vaccine, they got COVID, I'm not going to go ahead and get the vaccine, regardless of what this committee and anybody else says. And that also begs the question of what to do about boosters. I get often asked in my consulting practice, I got the vaccine and now I'm being told by my doctor I should get a booster. My next question is, well, did you make antibody to the first set of injections? And why would you need a booster if you already made antibody? And at what titer of antibody are you regarded as immune? Is it 1 in 200, 1 in 400, 1 in 1,000? At what level of antibody, neutralizing antibody, is the individual regarded as immune? Because if you've made enough antibody, maybe you don't need a booster, even though the serotype and there's a lot of antigenic diversity amongst, the new strains of the COVID virus. Maybe if the antibody is directed at, a particular portion of the spike protein, maybe you don't need the booster. Then regarding the immune response that was described earlier by the working group, I had a number of questions there. Did the investigators look at things like cytokine gene polymorphisms? Everybody in this room, if I take a hammer and I bang you on the knee, the amount of swelling you'll develop in your knee will develop on your particular cytokine gene polymorphisms. We all make cytokines at different rates, and depending on the alleles that you carry for your cytokine genes, my knee may not swell, but Dr. Hibberlin's knee may get to the size of a basketball. And yet we have the same knees, I think, maybe. Was that work repeated by any other independent labs to confirm what their findings were, particularly with regard to IgG4 antibodies, the production of anti-idiotype antibodies, and the long-term effect on the Fc molecule of the IgG antibody, as well as the cytokine changes they observed? And then to echo what was said earlier, perhaps they were looking at patients who had been infected with wild COVID-19 or injected, mRNA COVID. So those are the questions I had, and I'd be interested to hear their response. Thank you.
And who would you like to respond? The CDC and the manufacturers?
So the questions for the CDC was, are there studies out there looking at antibody levels?
Yeah.
At which level of antibody are you protected? If you have enough antibody, do you need the booster?
Can we have the response from CDC first?
I don't believe we have specific. Okay, here we go. Perfect.
Yeah, sorry, this is Natalie Thornburg, Lab SME and NCIRD. So we have done quite a lot of antibody studies. There's a lot of published antibody studies. The manufacturers have done a lot of antibody studies looking at antibody responses after vaccination and infection. And most people do produce very robust neutralizing antibodies, which do seem to correlate with protection. The issue with upper respiratory virus infections is immunity tends to not be sterilizing for any upper respiratory virus infection or after vaccination, just because of the dynamic way the immune system works in infection happening at a mucosal surface and evolution of viruses. So it's hard to come up with a very specific number to say this is the level of neutralizing antibodies that will protect a person against infection. And then it's additionally difficult to establish a number because the dynamic nature of a person's antibody response, and that their antibody response today might not be protective tomorrow or against a lineage that emerges 1 week from now. So yes, neutralizing antibodies protect us, but it's such a dynamic environment with the viruses and waning immunity that a test today can't necessarily predict your susceptibility 1 week from now.
This is Dr. Malone. You just made some statements about correlation between antibody or neutralizing antibody and protection. But I'm trained in this area and I've worked on the development and performance of correlates of protection analyses, for instance, for flu. Are there any well-defined, characterized correlates of protection for COVID? Yes or no? The answer is no. There are no clearly defined by standard methods correlates of protection for COVID. Not cellular, not humoral, not neutralizing. None of those have been subjected to formal analysis to define them as a correlate of protection. So you really have no right to assert what your feelings or opinions are about whether or not there's a correlation between any of these outcomes, these adaptive immune responses, and protection. There is no established correlate of protection for COVID, period, full stop, and stop saying otherwise.
Can I, Martin, can I make a comment here? This is Cody.
Please, very short, Dr. Meissner.
Yeah, the issue of a correlate of protection is critical. There's no question. everyone is interested in having a correlate of protection. However, there is a reasonable measurement of neutralizing or binding antibodies that correlate with protection against symptomatic infection in the first few months after.
Where is that study, Cody? Show me that study.
I am happy to. It's in the New England Journal of Medicine. And
because it's more likely that the protection is afforded by the cellular response, not the antibody response.
Right.
We'll let Dr. Meissner finish what he says, and then Dr. Malone can respond to that.
Robert, you're absolutely right, and that's what I was about to say. We know that as time goes by, the frequency of infection increases. It's primarily mild disease. Protection against severe disease, defined such as hospitalization or death, persists. So the question of what is a correlate of protection is enormously complex, as you pointed out, because it involves multiple components of the immune system. So, but I think there is a pretty well established correlate of protection, and I'm happy to forward that to everyone on the committee. But that only lasts for a short period of time, Robert. Over.
Dr. Malone, you want to respond?
Yeah, sorry, I live in the world of actual clinical testing and pathology and approved tests, and these soft endpoints that you're talking about are not the same as a defined correlate of protection. It's a very specific outcome that requires very rigorous testing. I completely concur. It's wicked hard to define. But this throwing around, like, forgive me, our colleagues at the FDA repeatedly asserting that antibody titers in mice are somehow a predictor of effectiveness in SARS-CoV-2 vaccination is just, it is non-scientific. I'm choosing my words carefully. And in this bandying about of correlative protection as a term, I personally find offensive as somebody who's had to deal with this and live in this world for years and years and years. It is, as you say, Cody, I completely concur. It is a wicked hard thing to do. It's still problematic in influenza. In the case of flu, the correlative protection that's established by the agency is probably only valid for that type of vaccine. And in the case of SARS-CoV-2, these surrogates that are being used to assert protection are not correlates of protection. They are indirect indicators of an immune response. An indicator of an immune response is not the same as a correlate of protection. I'm sorry, Cody, to direct this at you. I appreciate that you understand the issue, but for the more general audience, this is something that has been repeatedly misstated and misunderstood by our colleagues in the media and our colleagues in the pharmaceutical industry and, frankly, in public statements from former CDC directors. Over.
Robert,
Dr. Meissner, please.
I need to answer, if I may. I need to answer because there are several points that need to be made here, because this is really a very critical point. And you are correct. There are, as Stanley Plotkin and his co-workers have pointed out, there are mechanistic correlates of protection and non-mechanistic correlates of protection. It gets into a fairly complicated discussion, but it's the mechanistic correlates of protection that are most important. A statistical association with an immune response that is not involved in inactivation of the virus is not a correlate of protection. And I think that's what you're referring to, and I completely agree with you. The difficulty is it depends on the endpoint that's being addressed. Remember, there are 4 different endpoints. It can be very severe disease due to COVID. It can be mild disease due to COVID. It can be asymptomatic infection with COVID, but still permits transmission, or it can be an immune response that completely blocks infection. So there are 4 different endpoints that one can use. And defining a correlative protection for each one of those is extremely difficult. It involves mucosal IgA, systemic IgG, a number of different subclasses of T cells. So that is a long discussion. But I think we do have a pretty well-defined, and I will send you a paper that was in the New England Journal of Medicine a couple of years ago that derived a result based on all of the vaccine trials. Over.
Cody, are we aligned?
Yes.
That the titer, as reported, cannot be used as a surrogate for protection of an individual?
It's such a complicated question. I'm not.
Okay, can we agree on this? That the mounting of an antibody response does not define protection.
There certainly can be an antibody response that does not confer protection. Yes.
Thank you.
Well, I think thank you for that discussion. I'm sure our friends in the media understood all of this with perfect clarity. I think Dr. Pollock was not quite done with, so please continue.
I appreciate the discussion that the two of you have just had, and I think any statement that comes out of this committee may want to include the fact that while this committee recognizes that COVID vaccine may not always guarantee 100% protection, this is what this committee advises, because the lay public, and there are plenty of lay people in this room, believe that if you're vaccinated, you are immune. And if I'm not immune, I then have to weigh up the benefit and risk of getting the vaccine. And if I think the vaccine doesn't make me immune, why should I bother to expose myself to the risk of the vaccine?
So thank you for that discussion. And Dr. Blackburn?
Yeah, thank you. So first, I just wanted to highlight the role of pharmacists in vaccine access, and as evidenced in the slides, that pharmacies administered approximately 67% of COVID-19 vaccines to adults over 18, and that we should consider that continued access to vaccines in pharmacy settings is essential to ensuring timely patient care. I also wanted to kind of tag on to the comment earlier about low uptake among healthcare professionals of the COVID vaccine coverage, which was notably low, reportedly around 10%. Were there any surveys conducted to better understand the reasons behind the low uptake? Additionally, was there consideration of whether high influenza vaccine rates may have been influenced by flu vaccine mandates in health systems and how that compares to COVID-19 uptake? And I do have one, I'll pause there. I do have another comment, but I'll let that be answered.
Yeah, let me ask our SMEs if this, I know there is a survey that's done of healthcare personnel. I don't know if it gets into reasons for choosing to vaccinate or not vaccinate against COVID. Let me ask our SMEs if we have any of that specific data.
Yes, thank you. This is Carla Black from the Immunization Services Division. First, I'll respond to the second part of your question. Those data that were showed from the NHSN rely on facilities reporting their documented vaccination coverage to CMS. So they're obviously they'll miss vaccinations where they don't have documentation. So a lot of the reason I think that you see higher flu coverage is because facilities are more likely to have requirements for flu vaccination, and they're more likely to provide it on site. So they're more likely to have that documentation. We do have also surveys of healthcare personnel, and the coverage from surveys is much higher. It's around 40% that reported being vaccinated. And that's overall, including non-clinical personnel. So if you look at just like physicians, it's closer to 50%. And when we ask reasons for non-vaccination, it's similar to the general population. They feel like they're not at risk of getting COVID, or they're not worried about getting COVID. So in times where there's more disease or new variants, demand for vaccines is higher. And also, if we look at whether vaccine is provided on site, coverage is much higher. So it's also a matter of access and convenience.
Okay, I also wanted to bring up some package insert considerations. Section 13.1 of the package inserts of Comirnaty and Spikevax. It states that the vaccine has not been evaluated for potential carcinogenicity, genotoxicity, or impairment of male fertility. So in lay terms, genotoxicity refers to the potential to damage genetic material or DNA. And while many drugs carry this type of language, some, for example, lisinopril, have actually been evaluated and specifically state no evidence of tumorigenic or mutagenic effects. But given the rising cancer rates nationally and the case reports were presented earlier, should additional studies be conducted to assess this concern more fully? And from personal experience, my mother experienced a dermatologic immune response following a COVID booster in early 2022 and subsequently developed EGFR positive lung cancer 2 years later. In my small hometown population of less than 13,000, 4 others in close proximity living within a 2 to 3 mile radius were also diagnosed with EGFR positive lung cancer. Could it represent a potential cluster? Would CDC epidemiologists be able to comment on whether such patterns are being tracked? Is it related to the vaccine, virus, environmental issues? Definitely worth further study. But when I checked with the Mississippi Cancer Registry, I learned they still rely on fax forms and do not track biomarkers, which is surprising in 2025. And given that many people have questions, more robust studies could help confirm or rule out potential risks.
For your questions to the FDA on the package, to further those questions on the package and so to the FDA.
Dr. Hogue, please.
Yes, I'm here. I apologize. I thought initially the question was for the CDC, but thank you for bringing that to our attention. And I agree with your statement that the backbone of any, of initial analysis of this should be good epidemiological work to determine if there really is a rise in cancer rates associated with the COVID-19 vaccines, and if there are specific types of cancer, and that would be a very good question also for the CDC to see if they've found any concerning trends. And then there are novel methodologies, of course, that are ways of looking into potential risks of carcinogenesis. But those are difficult studies to do in general. But again, I'm open to hearing people's thoughts here. And again, at the FDA, we are really here to protect the public's health and are appreciative of these questions and the information. So thank you.
So thank you for that. I think we'll continue with the next person on the list, which is actually, I'm the next person. So I have questions for Pfizer and Dr. Paul Ballmer. So before the meeting, Pfizer, you sent out some very important information, which I appreciate. And among that information, you described randomized controlled clinical trials, placebo-controlled trial for Pfizer vaccine in pregnant women. And I would like to commend you and congratulate you for doing a placebo-controlled randomized trials. That is what we need for these vaccines. So I'm very happy that you did that study. It was a small study. I think you had a little over 150 in each arm, vaccinated versus controls. And when we consider whether it's a drug or vaccine, when we consider that in pregnant women, one thing that we're always very concerned about are birth defects. And in the material you sent, there was a 4-fold excess risk of birth defect among the vaccinated mothers. well, the birth defect was in the child, but when the mother was vaccinated. And I calculated on my own, and it's a p-value of 0.05. So that is very concerning. I mean, the sample size is small, but it's very concerning to have a fourfold excess risk of birth defects in these pregnant women. And I think the vaccinations here was gestational weeks 22 to 32, but I might remember that wrong. So I would like to see if you would care to comment on that important finding.
Yeah, this is Alejandra Kurtman. I'm the head of the Vaccine Clinical Research and Development Group at Pfizer. Thank you for the question. So the study was done at the time where, or the study was initially designed at the time where we did not have a recommendation for pregnancy. And so to your point of why the study was small, the study was interrupted when the recommendation became available for all pregnant women based on the risk benefit that was assessed at that moment for pregnant women. To your point, the vaccine in the study, which was about 350 women, randomized 1-to-1 to vaccine and to placebo, were given between 24 to 36 weeks of pregnancy. And the rates that you are referring to congenital abnormalities were about 5% in the vaccine group and 3% in the placebo group. So there is not a fourfold rise as you are referring. And the background rate for which these congenital abnormalities were seen was same or below what you will expect in pregnancy. So congenital anomalies, as everybody knows, happen in pregnancies, and the rates that were seen in the study match what you will expect in the general population. Of note, most of these congenital abnormalities are part of the first trimester of pregnancy, so most of them were present prior to the vaccination. So it would be very hard to think that the vaccine actually had any causality on anomalies based on the fact that the vaccine was given much later than during the first trimester of pregnancy.
So there were, I believe there were 8 birth defects in the vaccinated group, and there were 2 birth defects in the unvaccinated, and 8 divided by 2, since there was almost a 1-to-1 ratio, so 8 divided by 2 is 4. So would you agree that there was a fourfold excess risk or fourfold excess of birth defects in the vaccinated group?
No, as I mentioned before, the rates of the proportion of congenital anomalies in the two groups are about 5% versus 3%. And again, I'm going to repeat, those are very much what you will expect in normal and regular pregnancies.
So in the material that was sent, there was 8 in the vaccinated group. Is that wrong, that number? And there were 2 in the unvaccinated group. Is that number wrong?
There are 2 tables in the CSR that actually Pfizer public in the spirit of transparency. And the congenital anomalies can be seen in different ways, can be reported as serious adverse events, which is the table that I'm referring to, or they can be reported as adverse events of special interest. If you look at all of them as SAEs, that's the proportion that I'm talking between 5% and 3%.
And are you denying the 8 birth defects in the vaccinated and the 2 in the unvaccinated? Are those numbers wrong?
I'm not denying the tables are published on the Pfizer website for everybody to go and take a look at what I just described.
She says she's not denying the data.
So you agree that there were 8 birth defects in the vaccinated group and there were 2 in the unvaccinated?
No, we need to refer to the tables I am mentioning and to look at the differences between serious adverse events and adverse events of special interest.
Yeah, she's bundling them into total SAEs as opposed to just looking at the specific AE of teratogenesis.
In the material I read, there were 8 birth defects in the vaccinated and 2 in the unvaccinated, and they were not the same type of birth defects, but it was 8 and 2. So I'm confused if are those numbers wrong, 8 and 2. I would like to know if those numbers with 8 birth defects in the vaccinated group and the 2 in the unvaccinated group, if those, which I saw in the material that you sent.
I'm referring you back to the way that I'm describing.
Are those numbers wrong or are they correct?
I am referring you back to the way that we describe the data, where the data can be seen in 2 different ways. And we are happy to resend that to you if needed. I do want to acknowledge again that the birth effects that have been described in the study
reported on clinicaltrial.gov.
These are from the randomized placebo-controlled trials, and I think it's great that Pfizer conducted a randomized placebo-controlled trials for vaccines in pregnant women. I think that was a great thing to do, and I compliment for doing that study. But I'm confused because the material that you said there were 8 birth defects in the vaccinated group and 2 in the unvaccinated. And it seems that I want to know if you think those numbers are correct that you presented, or if those are wrong.
Excuse me, a point of order. All birth defects occur in the first trimester, and that was not when the vaccine was administered to the pregnant women. This is Carol Hayes with the American College of Nurse Midwives.
I would like to speak to that.
I would think that the birth defects is something that you find out after birth.
If I make a comment, so are we? I'm not familiar with this particular study. Where was it listed? What congenital anomalies were?
It was a variety. I don't remember them, but maybe Pfizer can answer what type of birth defects were these 8 versus 2.
Yes, there are congenital anomalies, although the major structural development occurs earlier, prior to 24 weeks, but there's others that can develop after. Can you tell us, can you list each one of the anomalies?
Yeah, they're described on the table that we put, that we posted online, the request of.
Thank you. Yes, we're not looking at that material. We don't have it on screen. Can you please read them? Dr. Koldorf said it was 8 in one arm and then 2 in the other arm. If you can please read each arm for us.
We will pull the table here in the room where we are, and we can come back with those.
Okay, just to finish the thought, after 24 weeks, we could develop, for example, microcephaly, ventriculomegaly, kidney anomalies, for example. So that's why I was asking the specific anomalies. Thank you.
And I know we have other representatives from Pfizer on the line. Is there a comment from Dr. Ballmer on this issue?
No additional comment from Paul Balmer.
Thank you. So we will now move forward, and we have Dr. Stein, please.
Thank you. I will try to keep my questions to first, I'd like to go back to something that both Dr. Meissner and Dr. Milhorn were talking about in terms of the high incidence of hospitalizations in babies less than 6 months. I noticed that the other analysis later presented about vaccine effectiveness and stuff, and hospitalizations were stratified by comorbidities. Was there a way, or was that a consideration looking at the babies?
Let me ask SMA room. So I believe the numbers were probably too small. SMA room, do you want to answer that question? Stratification for the infants.
Is
Hi.
Dr. Taylor on the phone? Yeah. Go
Yes.
ahead.
Hi. Could you please clarify your sentence? I'm wondering, are you asking about the hospitalization rates or prevalence of conditions?
No, I'm asking, is there a way to explain that relatively high incidence of hospitalization in babies less than 6 months old? Is there any knowledge or data on any kind of comorbidities or anything like that?
We do collect data on comorbidities for all of our age groups. I know, for example, for some age groups, I want to say 6 to 23 months, which I know is not the age group you're asking about. Prematurity is prevalent at about 20%. We have previously presented some data to this committee. It was not in the slides put forth for this meeting, but we do have data on underlying medical conditions among all age groups. I guess I would say in general, I don't think the patterns that we see in that particular age group differ other than, and I'm not a clinician, but I believe it takes some time for a child to develop the underlying medical conditions that we collect data on. So they might not be prevalent in that age group because it's just not a relative condition for children of that age.
Let me ask Dr. Patton to comment as well. I believe she has a comment.
Hi, thanks for the question. Yes, we definitely look at medical conditions amongst all our patients, as Dr. Taylor said. And among infants less than 6 months, the majority of them were healthy, previously healthy, had no underlying medical conditions. 71% of those infants that were hospitalized with COVID, due to COVID, had no underlying medical conditions.
Okay, 71%. Thank you. Healthy. My second question also goes back to comorbidities, because I find it, I think that's going to be an important topic, right, in terms of identifying risk groups. And in looking at, let me see if I can find the right slide. I've been back and forth so much. Looking at the vaccine effectiveness analyses, and there was a really striking here. I don't know if this is slide 22. You don't have to pull it up. There's a graphic showing the vaccine effectiveness in immunocompromised adults, age 65 and up. I don't think there is another analysis looking at stratified by comorbidities, and that's probably a limitation of data you don't have. But I was wondering if you could comment about the implications of that. And this is not like a gotcha question, because that's one of our groups that we're most concerned about, right? Are the groups that are immunocompromised, and then following from that, individuals that have comorbidities. What are your thoughts about the decreased vaccine effectiveness in that group?
Yes, thank you. This is Ruth Gellis in the SME room. We do collect data on underlying conditions, including both immunocompromising and non-immunocompromising underlying conditions. As part of our standard analyses, we do sensitivity analyses, generally either stratifying or controlling for non-immunocompromised underlying conditions. And we find very consistently that non-immunocompromising underlying conditions do not impact vaccine effectiveness. So in other words, folks with non-immunocompromising underlying conditions have the same effectiveness of the vaccines as those with no underlying conditions. That's not true for immunocompromising conditions, where we do often see vaccine effectiveness different in those with and without immunocompromising conditions, which is why our primary analyses generally stratify by immunocompromise, and then either control or not for underlying conditions that are not immunocompromising.
Can I jump in a question on that one? The issue of immunosenescence, elderly condition is one of your risk factors. It's well known to be associated with immunosenescence, which is associated clearly with reduced vaccine immunogenicity and responsiveness. So are you telling me that elderly cohorts that are prone to immunosenescence respond just the same as younger cohorts to these products? Over?
No, when we refer to underlying medical conditions, we're not talking about age. We're talking about things like cancer, diabetes. We do separately stratify by age by age group, because as you say, we do know that older age groups may have immunosenescence. We generally recently have not had statistical power because of lower vaccine coverage rates to stratify above age 65. What we saw earlier in the pandemic, when quite a bit higher, and we were able to stratify by 10-year age brackets above 65, is that we do see a drop-off in effectiveness happening around age 75. And that has led to recent recommendations for a second dose annually for those 65 and up who may have lower or may have more quicker waning.
Thank you for that.
Okay,
And Dr. Stein?
Questions, I think. Well, more one question, one comment. I'll skip one of my questions. In the vaccine safety signal and presentation, there was a table presented with a long list of adverse events of special interest. And I'm not sure this is a complete list. And so I guess it's a two-part question. One is, why was the analysis, other than time limitations, which is very reasonable, why was the focus only on stroke? And were there other conditions considered that are not on this list but potentially could be?
Thanks for the question. So with regards, and if you could pick up slide 13, please. So that's a list of the different adverse events of special interest that are being monitored via VSD. And I'm sorry, your question was, were there other conditions being monitored?
Yes, that's one.
Okay.
Yeah.
So I should emphasize that we have a number of complementing vaccine safety monitoring systems within CDC. And they are designed for different purposes. So in this case with VSD, the example that I went through, I was using that as an example.
Okay.
Okay, but that's a robust statistical analysis. But if we're talking about looking at our passive surveillance system comes in. Now, it's not designed to determine causality or statistical analysis, but it is designed to pick up on potential changes, reporting pattern, things we haven't seen before that can be pursued more robustly with a system like VSD. So each system has its design for a certain purpose, and they have their strengths and they have their limitations, but they complement one another. And together they cover a lot of ground.
Thank you. And my last question, my last comment is just a really simple one. Actually, it refers back to something Dr. Milhone said. I think Dr. Srinivasan did a really nice job presenting the vaccine effectiveness analysis because you didn't overplay it. Like the limitation of the test negative design is that if your sample is limited to who's coming to the hospital, right? And you were very clear that these are individuals who are presenting with respiratory symptoms and stuff. And so what I'm making I'm not disagreeing with anybody at this point. I'm just explaining outcome, and that's one that we really can understand. I think you guys did a great job really hone down and get due to, as opposed to, I think that's a very important interpretation, and people to not over-interpret, kind of going back to Dr. Pollack's point about, you know, this doesn't mean that that's the vaccine effectiveness against infection. It's a completely different outcome. Thank you.
Thank you for that. It's also very important to hear from our liaison members. So the first, Dr. Hayes, please.
Yes, Carol Hayes with the American College of Nurse Midwives. First of all, an excellent job of presenting data that we have been monitoring for the last 5 years. And I also wanted to give a shout out to Tom Shimabukuro, who worked on VSafe, and that's where we first began collecting data on pregnant women being vaccinated. And he did a fabulous job. So thanks, everybody.
Thank you for that. Dr. Freihofer.
Thank you. I'm Sandra Freihofer. I'm a general and internal medicine physician in Atlanta. I'm in full-time practice. I'm also an adjunct associate professor of medicine at Emory. I've been an ACIP liaison for nearly 20 years, and I've served on multiple vaccine work groups including the COVID vaccine work group since its inception until the liaison were removed from the work group deliberations. And I want to say that the presentations today on the biodistribution and the T-cell studies were fascinating. They were technical, they were complicated, they were confusing. And I was surprised that this preliminary research was presented at this level and not at the work group level, but it does call for the need for more research. And as we all know, on August 5th, HHS delivered a death blow to mRNA vaccine development by canceling $500 million in contracts for mRNA vaccines. HHS terminated 22 grants supporting refinement and development of mRNA vaccines. And canceling these research grants leaves us highly vulnerable to the next pandemic. It also puts development of mRNA-based cancer treatments at risk. And as we know, mRNA vaccines funded by Operation Warp Speed were essential to ending the COVID pandemic. They saved us during the pandemic. I also want to point out that the decisions this committee is making today really hit home for me. I have 2 grandbabies on the way. Both are due in November. And will these little babies be able to get COVID protection from maternal vaccination? Will they be able to get their COVID vaccines when they're 6 months old? We've heard the data. Rates of COVID hospitalization for children are highest under the age of 2. Babies 6 months old are too young to be vaccinated. They're at highest risk, and maternal vaccination can lower that risk. So please make these vaccines available to protect these little babies. I also want to
Thank
make
you, Dr. Hopkins, please. Dr. Hopkins.
Yeah, may I say one more thing, please, sir? I've waited very
ahead.
patiently. I also wanted to make a quick statement on behalf of the American Medical Association as AMA liaison. AMA has traditionally acted as a liaison to ACIP, and it's troubling to see the erosion of the committee's integrity. We're concerned about how vaccine recommendations are being developed by this new panel. Data is being selectively used to justify specific conclusions rather than considering all of the available evidence. And this lack of transparency diminishes trust, introduces bias, and raises doubts about the reliability of the committee's vaccine guidance. In June, the AMA and 79 medical societies confirmed their support for vaccines as the best protection during respiratory virus season, and this includes COVID vaccines. It's crucial to keep vaccines accessible to protect everyone, especially those too young to be vaccinated and those who are immunocompromised. The administration has stated it will continue to make vaccines available to everyone who wants them, but we observe federal policies that contradict this goal. We urge
You're
the
taking time away from other liaison members, and I would like to ask that you limit your comments to things that are directly related to the COVID vaccine. So thank you, Dr. Freihofer. Dr. Hopkins, please.
Thank you for the acknowledgement. This is Bob Hopkins. I'm Medical Director for the National Foundation for Infectious Disease. Just some brief comments. I think it's important to note that we continue to see severe disease due to COVID-19 leading to hospitalization and deaths. The impact is greatest in our population 75 and older, but is also significant in younger adults and in our youngest children. It's important to note that while the morbidity and mortality are greatest in adults who have comorbidities, that's not true for children. Children, the greater proportion, do not have comorbidities that end up in the hospital with severe disease. Our vaccines remain effective to reduce severe disease across all the age groups that have been tested, and any protection you get from the vaccine raises what little, none, or potential protection you have from previous exposure to the virus. Remembering that our children under 6 months have no protection that they get before mother being vaccinated at all. It's critically important that we maintain access of COVID-19 vaccine to all who want the vaccine. And low uptake, as Dr. Meissner had said, low uptake should not limit access to those who want to be vaccinated and reduce their risk for severe outcomes. Thank you.
Thank you very much, Dr. Paulson. Do we have Dr. Paulson?
Apologize, sorry about
We
that.
move
Thank
on.
you. Thank you very much for the acknowledgement. This is Grant Paulson with the Pediatric Infectious Diseases Society. As was mentioned yesterday, very clearly when we were talking about Hep B, there are populations in the public where trust in vaccines is low. I don't think anybody in the room or online is going to disagree with that. I think the hope from all of us is that the efforts of the ACIP committee continue to clinically review the science, raise concern where warranted, but also endorse the safety of vaccines when there are data supportive of that. As mentioned by the chair yesterday, open discussion is vital, as is an open mind when looking at the data, I think on all fronts. So with that said, as part of today's discussion on COVID, I understand the work group values are not necessarily, they don't endorse in using the statements of safe and effective as discussion points. With respect to safety, I understand that point. So we, as doctors, when we say something safe, as we've already talked about, that is partially accurate. There is no such thing as 100% safe vaccine or intervention in medicine. It is on balance with the risks and benefits. And so that is probably a misnomer in some sense, but the writ large message for the public is on balance, the risks and benefits are acceptable when we talk about safety. Data on effectiveness, I think effectiveness should be discussed, right? I'm not talking about correlates of protection. I certainly agree with all the prior statements on that. But we've just had excellent presentations by the CDC on incidence and safety, as well as effectiveness of these vaccines. So what I guess my concern is relying on case reports, anecdotes, and sort of selected basic science data. Is that enough to justify a change in policy or a recommendation that limits an effective vaccine based on concern rather than data on concern, the data on safety or adverse events? The data presented by Dr. Carlton on myocarditis was actually fascinating. I could quite closely geek out on that and talk to him and ask lots of questions on the genetics of vaccine-induced myocarditis versus that induced by COVID itself or other causes. I think further research monitoring is certainly warranted. But with that said, the data are fairly clear. Young children in the less than 6-month-old, but then specifically in the 6 to 23-month-old that would be vaccine eligible, have similar risks to 50 to 64-year-olds. And of the children, over 50% of them do not have a comorbidity or underlying health problem. They're healthy children that get admitted to the hospital. And we know the vaccine is effective for them. So as a pediatric infectious disease provider, really my belief is that no one here online or in the room is out to harm children. I think we all do want to protect them, minimize harms and risks. But I would encourage the committee to make decisions based on the data rather than theoretical concerns that are raised. Those are certainly valid concerns. I'm not here to dismiss them. Continued monitoring, continued research is vital, but should really not be a barrier to families looking to access this tool to protect their children. My only question, and I will wrap up, for the committee is, in the interest of transparency, can the language for the proposed vote be made available to the public prior to that presentation? Thank you very much.
Thank you for that. And Dr. Munoz?
Thank you. Flor Munoz with Infectious Diseases Society of America. Appreciate the acknowledgement. And I will be brief as I agree with the comments provided by many of our liaison colleagues as well. I just wanted to point out the fact that these discussions today are relevant and very important indeed, with many scientific questions brought up, which really support the need for additional funding to be able to continue to address this. In terms of the mRNA technology being a breakthrough technology that has allowed for the control of a pandemic in the US and globally. And the fact that the mRNA vaccines in particular have been given to more people than barely any other vaccine in the short period of time, which allow us to have precisely a lot of information regarding their safety and clinical trials with efficacy and post-authorization trials with effectiveness that support their utilization. Apologize for the sound. I also wanted to briefly mention the fact that the mRNA vaccine is the one that has been, for the most part, utilized in pregnancy, and that we have sufficient evidence to indicate that this is a very important intervention to protect those infants who are not eligible for vaccination. And my last request is to advocate for our most vulnerable populations, the older adults, the immunocompromised, and those with high-risk conditions, and the very young children, especially those under 2 years of age, and more importantly, of course, the less than 6 months who depend on the maternal antibody, but under 2 who need their own vaccination as well, to be able to receive these vaccines in the future with, acknowledgement again that there may be several questions to address for which we do need the research money, we do need the follow-up, and we do need a long-term investigation so that this technology could also be applied to future vaccines. Thank you.
Thank you, Dr. Buchanan.
Good afternoon. Thank everyone for the rich conversation that we've had surrounding the COVID-19 vaccine. I too would like a little bit more clarity around the question that we're answering today as it pertains to COVID-19 vaccines. I have great concern here in Georgia with access. I know earlier this year, it was stated that there shouldn't be issues with access, but unfortunately, with what we have as far as guidance, a lot of the providers here in the state of Georgia are limiting access for their patients. And I'll just give a very brief example of a colleague of mine whose grandchild is yet to be born and has 2 older siblings. And the mom reached out to their pediatrician to try to get the vaccine and was denied. And so that's what's going on. Like, we need clarity, please, about what the question is, and also to make sure that the vaccine is accessible for those that want it, which is a barrier currently in real time here.
Thank you for that. And we are now going to continue with a presentation by Dr. Ratzef Levi on the COVID-19 discussion framing. So please.
I'm going to try to be short as possible, but I do want to reflect the work that was done. I'm going to just wait for the slide. So again, it was a pleasure to work with the colleagues on the work group. We had heated debates, but also very respectful debates that maybe show that you can have good conversations and disagree on things, but nevertheless respect each other. So I want to start with the main takeaways of the work group. And when I say the work group, I mean most of the majority of the work group. Clearly, there wasn't consensus on everything. So the first point is that many of us, or most of us, felt that the current assessments of protection levels provided by COVID-19 vaccines, and especially the seasonal boosters against severe outcomes, namely hospitalization, ICU, deaths, and long COVID, are based on very low quality data and analysis. And that's kind of a major uncertainty that I think we all have to acknowledge. We also would like to flag that vaccine injuries are demonstrably not recognized by current pharmacovigilance systems. And in many cases, they leave vaccine-injured individuals abandoned and without appropriate care. And this is something that we intend to follow up on. We feel that that's something that is morally wrong, and also from a public health perspective, has to be addressed if we want to have trusted vaccine programs. Finally, we assess that there is ample published research. This is not hypothetical. This is ample published research that suggests some serious safety uncertainties and concerns, including potential adaptation related to mRNA vaccines that are currently not appropriately addressed. As high-level kind of recommendation directions, I want to flag out that for this meeting, we feel that one of the recommendations is about that the risk and uncertainties related to the COVID-19 vaccines should be appropriately communicated by CDC to patients and medical providers to enable appropriate informed consent. I'm going to be more specific about what we mean in that respect, because that's going to be a topic for a vote later on. A more longer-term goal that we put for ourselves to pursue in the next coming months is to work on recommendations related to development and enhancements of national efforts to appropriately diagnose the vaccine injured and care for them. We are going to follow up with more specific recommendations, and we have a lot of people in the work group that are very experienced with both academic research and field experience in caring for vaccine injured and also long COVID patients. We also plan to follow up on recommendation with respect to the development and enhancements of a national safety surveillance systems to address safety uncertainties and assess the impact. So we already kind of had discussions about the reliability of the assessment of the protection that COVID vaccines provide. And I want to make it much more crystal. So the key metric when you want to assess protection of a vaccine is what is called the number needed to vaccinate. This is basically the number of people you need to vaccinate in order to prevent one outcome. And despite many requests, including from the FDA about the number needed to vaccinate that were used to authorize the recent products, we were not able to get any numbers. This table is taken from something we've seen earlier today. This is a model, this is a simulated model that was presented previously by our colleagues at the CDC. Just to kind of make the point, what we see in the next slides this is data that is taken from the health authorities in the UK that developed similar analysis. And it's kind of puzzling to see the difference in the numbers needed to vaccinate that basically are between 6 times or even more larger based on the UK analysis, which leaves you kind of concerned about what the right numbers are and also what is the true efficacy and true benefits that these vaccines provide. And again, we are not in 2020 or 2021, we are in 2025 after multiple boosters, after drifting of the variants to be much less virulent. So these questions seem to be critical, but they don't seem to currently have reliable data. And we were very concerned by that. And by the way, we feel that should be communicated to patients. We already talked about the concerns around the definition of what a COVID hospitalization is. I'm not going to repeat that. We talked about that. But there are other methodological limitations, and specifically the current method used to assess the vaccine efficacy, the negative design control, is something that is clearly known in the literature. This is from the literature, that is not appropriate to assess the vaccine efficacy for mortality and hospitalizations. Without getting into too many technical details, I think that the major assumption here is that we are trying to assess the proportion of vaccinated people in the population by looking on the control cases, assuming that they are not associated or correlated with the vaccination status, and take them as a proxy. But there are many, many biases to this. And just to, again, we're short on time, so I'm going to run fast here. But this method will show that the vaccine is efficacious, even when the vaccine has neutral impact on COVID and will make you more vulnerable for other cold viruses. Something that, by the way, the latter is something that there is some evidence to it. So this method cannot even distinguish between a situation when the vaccine maybe have negative impact, right, than in a situation when the vaccine is efficacious. So again, I'm not trying to say what the answer is, and I'm not trying to judge the specific results or trying to infer here what the specific efficacy of the vaccine is. But I'm making a point here that the biases are all over the place, and this is really not reliable methodology. And unfortunately, we are using it and ignoring a lot of other approaches that could be used. Some we are ignoring because maybe limited access to data that we need to address. But that, and again, I'm very happy that the FDA declared that they have intention to run randomized control trials. I think it's due, and we have to get reliable data on efficacy. just as a side point, the RCTs that we know we have for the mRNA vaccines did not show benefits for all-cause mortality and all-cause hospitalization. In fact, there's some evidence to suggest that maybe they caused harm in that respect. Okay. Other concerns, we are concerned about the short-term protection that these vaccines are providing. Even the most optimistic assessments talk about several months, and that's it. And given the fact that the SARS-CoV virus has 2 waves in a year, that's kind of a major reason for concerns. And finally, we are concerned by emerging literature that suggests that especially repeated vaccinations, but maybe any vaccination, can increase the vulnerability to other respiratory virus. That is something that even analysis of the children, meta-analysis of all the children trials that were done suggests that they were more vulnerable to lower respiratory tract infections, including RSV, which is a far more severe virus when it comes to children. So all of this makes us very, very concerned. And maybe just end up by a slide that we saw today. And I just want to point out that the curve, the red curve, is much, much lower than the previous year curves. The red curves represent the last season. So without significant change in vaccination rates, we see a major decrease in the incidence of COVID, which suggests that other factors are really driving this virus, fortunately, to be less virulent and cause less harm. And this is good news. This is good news. And it's definitely something that we need to continue to monitor because the trend can change. But I think we need to also acknowledge the fact that we have consistent, over the last couple of years, we have consistent trends that of lower virulence and not necessarily related to vaccination rates. I want to move and talk about some safety concerns. I think that was another thing that the work group members felt the CDC currently does not appropriately acknowledge several safety concerns and uncertainties. I want to point out, in particular, outcomes and prognosis of myocarditis and cardiovascular adverse events, clinically documented prolonged vaccine injuries, specifically post-vaccine syndrome, and multiple documented unintended mechanism of actions of the mRNA vaccines, and seemingly regulatory violations. I want to take a few minutes to talk about deaths from myocarditis, because that was something that was not discussed. What we see here, this is published literature from the US, 2 cases, 3 days and 4 days post-Pfizer dose 2, analyzed by a pathologist from Yale University and a team, is basically saying the findings are utterly not typical to viral infection that causes myocarditis. And they conclude that in all likelihood, these kids died in sleep because fulminant myocarditis after vaccination. The CDC response to that is that they don't believe that necessarily this is happening from the vaccine because they found in one of them virus, some other virus, and in another one a bacteria. And the response of the pathologist is that essentially this is not typical to viral infection, very different pattern, and the other bacteria is something that is typical to post-mortem kind of autopsies. I have to stop here, and I want all of us to ask, do we have a culture of safety? And what would it take for us to acknowledge that there is a problem when at the same time, someone that died 2 weeks after a positive COVID infection will be considered a COVID-associated death, whereas kids that die 3 days from a known mechanism of the vaccine in their sleep are not counted as vaccine deaths? I hope that we all can agree that there is a problem here. And I think we need to we need to adopt a more safety culture that really acknowledge that when there are problems. Again, this has nothing to do whether we need to take the vaccine or not. This has to do with acknowledging what the risks are and be truthful to parents and patients about what are the risks. And these kids died from subclinical myocarditis. And I want to point out that we have 2 studies that tested people before and after vaccination. And in both of them, between 2 to 3% of the people that took the vaccine had hallmark biomarker of a heart damage and heart attack. This is namely elevated troponin. This is published literature. And moreover, published literature from other countries suggests that you can actually die from that. And that's actually consistent with long-term literature about subclinical myocarditis. We currently completely ignore this aspect. And I want to emphasize two things here. First, look at the number of males and females, because we kind of adopted the perception that this is only a problem for boys. This suggests to me that potentially we need to recalibrate our perception because seems that females are also affected. And the other thing that I would like to emphasize here is that subclinical myocarditis can cause death. It's proven. It's not questionable. And nevertheless, we are not talking about this with patients, and we are not stating that risk. And the last thing I want to say about this, that it's well known in the literature that the long-term prognosis of myocarditis is problematic. Now, we don't know what will be the specific prognosis of these individuals that were harmed by the vaccine, but I'm not sure we have any monitoring system in place to actually monitor that or even understand the scope of the problem. And that to me, again, that's to the work group, was a big problem. The other thing I want to say, that the injuries of PVS are prolonged, debilitating, and involve diverse symptoms and conditions that may be overlapping with long COVID injuries. These symptoms include a range of conditions. I'm not going to get into this. The doctors that care for them, that are part of the work group, can classify it as much better than me. But I do want to say something very important. We don't know the frequency of PVS, but one thing is clear, that our current system that really looks on diagnosis is not going to capture them. And the reason is that there is no diagnosis to these conditions, and that the symptoms are so diverse. Some of them actually are common to transient symptoms that you have after vaccination, but just prolonged, and they continue for years. And this is just a recent paper, still unpublished, but very fascinating, by Professor Christine Stable-Ben, that actually describes why we should be very concerned that our current approaches to safety are not going to capture those. So this is taken from the CDC website. It explains to people how the mRNA vaccines work, and it tells them that the mRNA and the vaccine clears from the body shortly after vaccination. That's not true. And we heard the lecture, the fascinating presentation from the people in the work group. Again, I want to go back to a culture of safety. One of the things when you think about safety of complex systems or products, if they don't work as intended, that's by itself a safety concern, and you have to actually be very concerned about that, even without knowing what the specific outcomes or consequences of that would be. And we have a range of things on the mRNA platforms that really suggest that it doesn't work as intended. And I think that we all have to consider that when we think about the safety of these products. Vaccination and pregnancy was a highly debated thing among the work group. I think that there were people that felt that we should recommend pregnant women to vaccinate for the reasons that people mentioned here. But most of the people felt that there is strong reason actually not to recommend them. I think that after all, we decided not to bring it to a vote today, but we do hope that the FDA and the CDC will look much more carefully into this, because most of us are extremely concerned about the safety and the lack of robust evidence, both on safety and efficacy for not only pregnant women, but their babies. This is something that I think really deviates from any standards that we knew in the past. Vaccine-specific recommendation, this is something very plausible. We didn't feel that we have time and enough data to make those kind of distinguish recommendations, but I do want to point out two things. There is one study that suggests that the adenovirus vaccines that were part of the initial launch of the vaccines in 2021 actually did reduce all-cause mortality in clinical trials, whereas the mRNA vaccine didn't. And the other thing is that there are also multiple studies that show that Moderna provide higher protection against COVID and lower rate of adverse events. This is again published data from multiple studies from the VA and other places. So I think that going forward, we want to encourage the FDA to really think, and the CDC to really think about more nuanced recommendations, and including considering vaccines that potentially are not currently authorized in the US, because we want to find the best trade-off of risk and benefits for patients. I do want to talk about public trust because I think it's a critical thing. I don't think that the public currently believes to the narrative of safe and effective. This is kind of a recent poll, and this is just building up on prior polls. And the trust is not just a problem among the public, it's among the people. We saw this slide today, 8% of healthcare workers believe the current recommendation. What does it tell us about our ability to come and continue to forcefully recommend these products when the very same people that are supposed to administer them and recommend them show by their legs, by their action, that they don't trust and don't take them? I think that this is something that we all need to think about. Okay, so I wanted to quickly kind of talk about how this more specific kind of things that we wanted to bring to the table today. And the first thing was the informed consent. We feel that, or most of us felt, were very concerned that the existing administration processes of the COVID-19 vaccine products do not ensure a meaningful informed consent. We were very much relying on a recent paper that talks about this and really kind of states the ideal informed consent, but also really points out that the vaccine information statement that is basically the basis of most of the informed consents in most states currently for vaccination does not necessarily in its current form and the current way it's being administered play that role or play an effective role to facilitate an appropriate informed consent. We feel very strongly that that should be addressed. And that kind of led to our recommendation that the CDC engages in effort to create more consistent and comprehensive informed consent processes. And as part of that, considers adding language accessible to patients and medical providers to describe the following risks and uncertainties. The first one is current assessments regarding the protection provided by COVID-19 vaccines and especially seasonal COVID-19 boosters against severe outcomes, for example, death, hospitalizations, and long COVID, are of low quality. At best, the additional protection provided by a seasonal booster is moderate and of short term. Second, there is evidence that repeated seasonal mRNA boosters cause acquired changes in the immune system and may be associated with increased vulnerability to future infections, including SARS-CoV-2 and other respiratory viruses. These risks, as well as potential risk of autoimmunity, chronic inflammation, immune tolerance, and impaired immune surveillance, including immune fatigue or suppression, are not currently well understood. Third, there are documented deaths from symptomatic and subclinical myocarditis, pericarditis, and potentially other cardiovascular conditions post-COVID-19 vaccination, including of healthy children, with probable causal relationship to the mRNA vaccines. This risk is likely relatively small, but currently not well understood. Fourth, clinical reports demonstrate that in some cases, COVID-19 vaccines can cause prolonged and debilitating post-vaccine syndrome, PVS. The injuries associated with PVS involve diverse symptoms and conditions, many overlapping with long COVID injuries. Some of the observed symptoms and conditions may include insomnia, chronic pain and fatigue, dysautonomia, like POTS, immune dysregulation and deficiency, autoimmune disorders, severe neuropathy, and neurodegenerative conditions, cardiovascular and neurovascular injuries, and severe clotting. The frequency of PVS and related risk factors are currently not well understood. 5, there is evidence that in some individuals vaccinated with mRNA vaccines, the resulting spike protein, the mRNA, and the nanolipids formulation components persist in different body organs, including lymph nodes and the heart, for a prolonged period months and possibly years in some patients. Prolonged and persistent exposure to spike mRNA and nanolipid particles is associated with post-vaccine syndrome injuries, as well as potentially other side effects that are currently only partially understood. 6, the safety and the efficacy of COVID-19 vaccines during pregnancy have never been tested in appropriately powered randomized clinical trials. In one randomized clinical trial, there was observed numerical imbalance of higher number of babies with congenital malformations among those born to vaccinated women. Now, I just want to clarify the context here. We are not expecting the CDC to use this specific language, but we really encourage the CDC, both for the vaccine information statement as well as other communication channels, to find the right language to communicate these risks and uncertainties to patients and medical providers, so we can actually have the appropriate informed concerns and discussion of risk and benefits that are realistic to the current knowledge and the current gaps in knowledge that we currently face. The last thing I want to say is to talk a little bit about the guiding principles that we took in order to kind of recommend the specific policy recommendations about who should be vaccinated and what form. Our first assumption was we want to access within the authorized FDA population, especially. Benefits and risk and uncertainty must be communicated as part of informed consent. We debated mostly between individual-based decisions and group recommendations. And I think that the majority of the work group felt strongly, but in a second we'll hear the minority opinion as well. The majority of the group felt that individual-based decision is appropriate. And specifically, we feel that these vaccines should now be prescribed as a prescription. And I want to say a few words about why. I think that there are two major reasons why. One is that when you try to quantify the risks and benefits, you very quickly, and we also already saw that in our discussion today, you get to a lot of nuance. Where you had prior infections recently. What is your immune response currently? What exactly are your comorbidities? How your comorbidities increase your risk for COVID versus risk from vaccination? We feel that this is too nuanced. And since we are not talking about now an emergency situation, we think that it's appropriate to bring it to something that is being discussed between a physician or medical provider and a patient as part of a prescription. Now, the other thing that causes that to feel like that there is also nuances of what products to use, and also what are the uncertainties and how they're being communicated. And I think the flip side of that, there is kind of a lot of concern about access, because you just heard that, for example, many people take it in the pharmacy. I do want to respond to that. If you think about who is supposed to take those vaccines, these are people that presumably high risk, have health conditions, and take other drugs, other prescribed drugs. So they are by design, or currently are engaged with their physicians with respect to different prescriptions, with different care, with different diagnostic. And we don't feel that for those patients, it would be something unreasonable to expect that there will be a discussion around whether or not they should be taking a seasonal booster or new vaccines. As I said, there was a minority sentiment in the work group, and we're going to hear soon from 3 colleagues, Professor Bernstein, Professor Miglis, and Professor Perlman, that I truly appreciate their engagement in the work group. And while we did not agree on all the things, they were instrumental in driving the discussions in the group. In the work. Thank you.
Thank you for that. Dr. Bernstein, please.
Thank you. It's an honor to be presenting today, and we appreciate this opportunity to present our thinking. Doctors Perlman, Miglis, and I are sharing our reflections on the recent work group considerations. None of us have any conflicts of interest. Next slide, please. This slide demonstrates the simple, stable recommendations can increase vaccine coverage. As you can see, as vaccine coverage increases, the red dotted line, disease incidence decreases over time, the blue line. It clearly highlights the delicate balance between perceived benefits and risks of vaccination. And now you note that this balance is linked closely to vaccine acceptance, as we've heard from others. And you can see when vaccine coverage decreases because of loss of confidence, outbreaks happen. And we heard earlier about the measles outbreak that we all experienced. Next slide, please. Vaccine development is a long and challenging process, often lasting many years and involving the combination of both public and private partnership. Operation Warp Speed was a huge success as COVID-19 vaccine continues to work incredibly well. Most importantly, safety is carefully evaluated at every step of vaccine development, even after the vaccines have been licensed and implemented. Next slide, please. Next slide, please. Thank you. The safety monitoring that has been conducted by the CDC has been historic, and it was needed because of the pandemic. We have talked about these different groups, and I'll focus specifically on VAERS, the Vaccine Adverse Event Reporting System. This is the country's early warning system for vaccine safety. Everyone needs to appreciate that anyone, the public, providers, anyone can submit a vaccine experience to VAERS. But it is important to understand that VAERS does not identify causality. Rather, it is a signal detection tool, and it's valuable in that way because then it can be explored in more depth. Next slide, please. Did I lose my slides? Are my slides projecting?
Sorry, we're working on it.
Thank you. Dr. Levy, is this problem because we had the minority opinion?
And no, I was cut. I can tell you, I was cut by half of what I was supposed to say. So I guess we cut everywhere. Right? But you remind me, I have 6 kids, and all of them think that I'm unfair to them. So I tell them that I'm unfair fairly to all of them together. So
We have the slides, so please continue, Dr. Bernstein.
Great, thank you. COVID vaccine, as I mentioned to you, COVID-19 vaccine safety has been extensive, continuous, and is ongoing. And you can see the different elements here on this slide. I do want to point out that the pregnancy registry maintains longitudinal assessment of both maternal and infant outcomes. And rapid cycle analyses monitor a small set of pre-specified outcomes to detect potential concerns that warrant further investigation. Next slide, please. COVID-19 vaccine is effective, providing additional protection against COVID-19 associated ER visits, urgent care visits, hospitalizations, and critical illnesses. As you can see on this slide, it's among children, similar with other age groups, hospitalization as well. And remember that some of the comparisons are for those that have been vaccinated versus those that have not been vaccinated. Vaccine effectiveness should be interpreted then as an additional benefit of COVID-19 vaccination in a population that has high levels of infection-induced immunity, vaccine-induced immunity, or both. Next slide, please. There are three pillars of the ACIP. Science is front and center, but there is much more. These three guiding principles help inform the decision-making of the ACIP. Science supports the COVID-19 vaccine works. It is incredibly safe and effective. But the vaccine also must be easily accessible for everyone who wants it. Next slide, please. Shared clinical decision-making and a need for provider prescription create barriers to COVID-19 vaccination. Healthcare providers always discuss vaccination pros and cons with their patients. And in principle, clear recommendations and shared clinical decision-making reach the same goal. However, with routine age or risk-based recommendations, the default decision is to vaccinate all patients that consent. Recommendations with shared clinical decision-making are perceived differently. Shared clinical decision-making has no default. Vaccination is often interpreted as optional. Plus, the need for a provider prescription creates an incredibly unnecessary step to receiving a vaccine and does not effectively target those at high risk. Next slide, please. We also need to remember that there are 330 million people in the United States, and there are more than 18 million children under the age of 5 who are more likely to be infection naive and/or unvaccinated. These are important considerations. Next slide, please. COVID-19 vaccine is safe in children 6 months to 11 years. And as noted on the red box, there are no confirmed myocarditis cases in children aged less than 5 years identified in VAERS or the VSD. And rapid cycle analyses in the VSD demonstrate no increased risks for 22 other pre-specified outcomes following COVID-19 vaccination. Next slide, please. Our CDC colleagues eloquently updated this data. This was from the June meeting. And as you can see, this figure shows that the rates of COVID-19 associated hospitalizations are highest among infants and children less than 2 years of age. The purple curve are those that are less than 6 months, and the blue curve are those that are 6 to 23 months. But you will notice that their rate per 100,000 population is still notable. And remember that a small percentage of a large number of children is a large number. Next slide. COVID-19 causes severe disease in infants under 6 months of age. As shown on this slide, hospitalization rates for infants under 6 months of age are comparable to those 65 to 74 years of age. As we learned, and it was just updated earlier, this young group has the highest rate of COVID-19 associated hospitalization among the entire pediatric population of more than 18 million. Next slide, please. Pregnant women who receive COVID-19 vaccination pass their protective antibodies to their newborns and young infants. We know that's effective with RSV vaccine antepartum. We know that works with influenza vaccine antepartum. We know that that works with Tdap antepartum. These are things that protect young infants who are not able to be vaccinated. This is very important because, as we said, infants under 6 months of age have the highest rate of COVID-19 associated hospitalization. Next slide. COVID-19 vaccine safety during pregnancy has shown no increased risk of these maternal outcomes, these pregnancy outcomes, or these infant outcomes. They are being closely monitored and should continue to be closely monitored. But we also recognize that the benefits far outweigh any risks. Next slide, please. This was mentioned earlier about immunosenescence. Older people do not have as good an immune response as when they are younger. So those 65 years and older notably benefit by getting vaccinated. And I fit into that 65 and older category. Next slide, please. So these are the key messages for consideration that Dr. Perlman, Maglis, and myself discussed with our COVID-19 work group. The ACIP pillars are not driven by science alone. That is front and center. But implementation and ethics are additional important considerations for vaccine accessibility. Simple, stable recommendations can increase vaccine coverage. COVID-19 vaccines are highly safe and effective. Or if we don't want to say safe and effective, they work. Shared clinical decision-making and the need for a provider prescription create unnecessary steps to receiving a vaccine and do not effectively target those that are at high risk. Next slide. COVID-19 vaccination rates in the younger pediatric population are very low. That's true. And many of them have not been vaccinated yet at all. And many of them are infection naive. So the primary COVID-19 vaccination series needs to be available to those millions of children. Antepartum vaccination especially helps protect infection naive newborns and young infants under 6 months of age. Older people do not make as good an immune response as when they were younger. So in summary, COVID-19 vaccination matters for pregnant women, pediatric patients, especially those less than 2 years of age, people 65 years and older, those of any age with a weakened immune system or chronic medical conditions, and anyone who feels they want protection for themselves or their families. Thank you for your time.
Thank you very much. And I presume that presentation was from all three of you.
Yes.
Drs. Bernstein, Perlman, and Maglis. We will now hear the proposed recommendations from Dr. Levi.
We are going to propose multiple votes. Maybe you can advance the slides. Okay. It is a sense of the committee that the CDC engages in an effort to promote more consistent and comprehensive informed consent processes. And as part of that, considers adding language accessible to patients and medical providers to describe at least the 6 risks and uncertainties included in the workgroup chair presentation. That's what I was just talking about. So that's going to be the first vote. The second vote, it is the sense of the committee that the state and local jurisdictions should require prescription for the administration of COVID-19, of a COVID-19 vaccination. That's kind of the second vote. The third vote, it is the sense of the committee that in conversations with patients before COVID-19 vaccinations, authorized healthcare providers discuss the risks and benefits of the vaccination for the individual patient. The discussion should consider known risk factors for severe outcomes from COVID-19, such as age, prior infections, immunosuppression, and certain comorbidities identified by the CDC, and include a discussion of the potential benefits and risks of vaccination and related uncertainties, especially those outlined in the vaccine information statement as part of informed consent. And the next one, the pediatric and adult immunization schedule for administration of FDA-approved COVID-19 vaccines should be updated as follows. Adults 65 and older, vaccination based on individual-based decision-making, also known as shared clinical decision-making. And then individuals 6 months to 64 years, vaccination based on individual-based decision-making with an emphasis that risk benefits of vaccination is most favorable for individuals who are at an increased risk for severe COVID-19 disease and lowest for individuals who are not at increased risk according to the CDC list of COVID-19 risk factors. I think these are the 4 votes that those 4 votes.
Thank you very much for that. One important part of ACIP meetings is to receive public comments from the public. That is very important. And it's actually also a legal requirement. So we will now go to the public comments. And I think we have 10 speakers. And the first one is Robert Blancato.
Yes, my name is Robert Blancato, and I am the Executive Director of the National Association of Nutrition and Aging Services Programs. We are the leading organization advocating for community-based nutrition programs for older adults. I have personally been advocating for broad, affordable access to vaccines for this population for decades because vaccination is the most effective and cost-efficient way to protect the health of the aging and to reduce the need for more serious interventions like hospitalizations. In just the past decade, the progress that has been made in the development of vaccines that specifically protect older adults has been astounding. Americans are older today than ever before. The number of Americans aged 65 and older is expected to increase from 58 million to 82 million by 2050. Ensuring these Americans remain healthy and thriving in large part depends on access to vaccines. To this point, we were very happy to see Secretary Kennedy confirm the CDC guidance for the RSV vaccine earlier this year to include individuals age 50 and over who face a higher risk of serious illness. We know that many Americans, and particularly people of color, begin to suffer from chronic disease and illness before the age of 65. Guidance that allows for earlier access to vaccines will give these Americans a better chance at a healthier and longer life. Just as Secretary Kennedy recognized with the RSV vaccine, we urge this committee to do the same with the COVID-19 vaccine because Black and Hispanic populations are disproportionately impacted by this virus at a younger age than white populations. The median age of Black patients being hospitalized for COVID-19 is 60, and for Hispanic patients, the age is even lower at 57. This is compared to the median age of white patients at 71. So it stands to reason that lowering the age-based recommendation for the COVID-19 vaccine below age 65 would keep more Americans out of the hospital and reduce overall costs to the health system. We also urge you to consider the priorities outlined in a letter led by the Alliance for Aging Research, which was sent to ACIP yesterday and signed by 75 organizations, including our organization. Our organizations are speaking with a united voice on behalf of a wide range of Americans who want to ensure the guidance on these life-saving vaccines is clear, broad, and equitable. Not everyone across the country will decide to receive every vaccine available to them, but everyone in this country should have the choice to receive a vaccine that is safe and effective and can protect their health. This also requires ensuring adequate vaccine supply at pharmacies where a large portion of Americans receive their vaccines. Lastly, I want to encourage the CDC to consider including committee representation of experts who have a background and experience in treating older adults. Vaccines support healthy living across the full lifespan, so recommendations for their use should also represent the expert opinions of those serving Americans in all stages of life. Thank you for the opportunity to present and provide these comments.
Thank you very much. Ms. Nisa Shafi.
Good afternoon. My name is Nisa Shafi, Director of Advocacy at the Allergy and Asthma Network. I appreciate the opportunity to present before the Advisory Committee on Immunization Practices in staunch support of vaccine availability and access for consumers across all health insurance coverage types. Allergy and Asthma Network is a nationwide nonprofit patient advocacy organization that represents over 100 million Americans impacted by asthma, allergies, and related conditions like COPD. Individuals living with these chronic conditions are at a greater risk of developing complications from infectious diseases such as influenza, pertussis, measles, mumps, rubella, COVID-19, and respiratory syncytial virus, or RSV. These conditions can exacerbate symptoms, leading to serious lung complications. Allergy and Asthma Network is deeply concerned about the recent changes to the national vaccine recommendations, which were originally shaped to emphasize the role of vaccines in attaining herd immunity, reduce complications and death, and mitigate public health disasters. Recent efforts in some states to hamper consumers' ability to receive COVID-19 vaccines without a prescription derails these immunization victories from Operation Warp Speed and will cause a ripple effect of access challenges, a spike in disease burden, and compromise herd immunity and increase health expenditures. Patients with asthma and other respiratory diseases rely on their vaccine administration to be covered by their insurance. ACIP's recommendations significantly influence insurance coverage for vaccines, as private insurers, Medicare Part D, and Medicaid are all typically required to cover vaccines with an ACIP recommendation at no cost. We are concerned that any changes to the recommendations will result in vaccines not being covered by insurance and will reduce or prevent people from getting the vaccinations they need. In 2023, over 3,600 people died from asthma, with African Americans experiencing 3 times the rate of disease burden than non-Hispanic white Americans. Nearly 49% of adults under the age of 65 report cost barriers to asthma care, and asthma costs the nation nearly $82 billion in annual healthcare costs. We must not introduce undue barriers that prevent people from fulfilling this vital duty to protect themselves, their families, and their communities. Allergy and Asthma Network urges the Advisory Committee on Immunization Practices to maintain effective public health messaging and strong vaccine recommendations. Without intervention, these measures will jeopardize guidance on other critical vaccines that benefit people with chronic respiratory conditions like asthma and COPD. Thank you so much for the opportunity to present testimony today and for the work that you're doing.
Thank you very much. And the next speaker is Mr. Noah Luis Ferdinand.
Yeah, hi. My name is Noah Louis Ferdinand. I'm the communications coordinator at Voices for Vaccines. We're a national nonprofit that helps families find evidence-based information about immunizations. I wanted to comment on 2 of the issues being discussed at this current ACIP meeting. First, I appreciate ACIP's decision to more carefully review the evidence on the Hep B birth dose. The evidence collected and reviewed by previous ACIP convenings is clear. Hepatitis B is a safe vaccine, and that timely birth dose protects newborns from what is an incurable chronic infection that creates a 1 in 4 risk of liver cirrhosis and cancer. Hepatitis B was the first cancer-preventing vaccine, and to maximize that cancer protection, the newborn must receive the vaccine quickly within the first day of life. That routine vaccine at birth is recommended, as not all mothers are tested for Hep B, as has been discussed here. And of those tested, results are not always available at the time of birth. It is not proven to be a public health strategy that works to just do the testing. When you revisit this issue, I would ask that you draw from the predominant experts in hepatitis elimination, who have made great progress worldwide, This includes John Ward, who is now the head of the Coalition for Global Hepatitis Elimination and the former director of the CDC's Viral Hepatitis Division. He submitted a written comment, which he asked me to mention here. The second issue I wanted to touch on is COVID-19 vaccine recommendations. At Voices for Vaccines, I frequently work with the parents of immunocompromised children who go to great lengths to keep them healthy, including getting seasonal COVID vaccines, which they're really getting for their children or other family members who might be vulnerable. Any vote to not recommend or remove COVID-19 vaccines for adults from the VSC program, I understand that's not being discussed today, but now or in the future, would remove or limit that option for them. In a country which, if we're being honest, does not really have a good plan to protect the immunocompromised from COVID. It's not something that I necessarily have to worry about as a healthy 26-year-old man, but I understand that there are people for whom this is really important. So I would really just encourage you not to limit access or to consider access in the future. I also think that much of the discussion of COVID vaccine safety today has been of questionable use to the public. I am grateful to the agency presenters who had very targeted and clear presentations, but some of the other discussion was based on speculation or questionable data. For example, the implication that COVID vaccines might change your DNA was based on a study of cancer cells, which, by definition are cells not functioning normally in a petri dish, which I just think we should be using higher quality evidence when we're making decisions for the nation's health. And so I would just urge a little bit more kind of quality when making such claims or implications. It was also suggested that COVID vaccines may cause cancer. I'm obviously very sympathetic to anybody affected by cancer, but there really is no evidence to support this. Early onset cancers have been rising, as was noted here, but that's a decades-long trend going back before COVID even existed. My own beloved uncle unfortunately passed away just a few years ago from brain cancer, so I understand just how serious of a claim is being made when we say that the vaccines might cause cancer. And I think that's when you really have to bring solid evidence to make before kind of putting that out to the public. Thank you.
Thank you very much. The next speaker is Mrs. Candace DeMatteis.
Good afternoon. I'm Candace DeMatteis, Vice President of Policy and Advocacy for the Partnership to Fight Infectious Disease. We're very concerned about recent changes to ACIP membership and movement away from the evidence to recommendations processes, and most importantly, what those changes mean for access to vaccines and the public's health. Historically, ACIP's strength resulted from its rigorous deliberative processes, moving from evidence to recommendations by engaging a variety of experts to examine the research, and that's what delivered recommendations grounded in evidence that people could trust. Historically, becoming an ACIP member involved more than a year of careful vetting, reviewing independent expertise, committee needs, professional qualifications, and conflicts of interest. Often voting members started on working groups, gaining critical experience and insight into the detailed processes that informed ACIP deliberations. Those working groups allow experts from multiple fields to review scientific and clinical data, including fully investigating adverse events, before sharing options with the ACIP for consideration. Traditionally, that's where data were examined instead of bringing up unvetted research and anecdotes during the course of discussion. Every current ACIP member was appointed outside of that process. Respectfully, that does not build trust or confidence. Yesterday's revelation that revisiting the Hep B birth dose arose not because of new evidence of risk reduction or safety issues, but because of vaccine skepticism was shocking. That is not gold standard science and further erodes trust. Tabling that discussion today was the right decision. Your recommendations affect access and choice to vaccines across America. Physicians rely on ACIP recommendations, and insurers and public health programs depend on sound recommendations to determine coverage. Recent changes at ACIP have so tarnished trust that several states are moving to divorce their vaccine policies from ACIP recommendations. That will mean disparate protection and access depending on the state of residence. The former recommendations for MMRV and existing ones for Hep B reflect the rigorous evidence-driven process that should guide ACIP decisions. Changes outside the evidence to recommendations process will lead to restrictions in access that will increase risks, limit coverage, and reduce access for families trying to keep themselves and their children healthy. On COVID, last year alone, polls estimate that more than 55 million American adults said they would definitely get a COVID booster. Their reasons vary and often include reducing risk to others. They should be able to make that choice. We urge you to recommit to and follow the processes foundational to ACIP's leadership. Thank you.
Thank you. And now Dr. Daniel Crawford.
Hello. Thank you for this opportunity to speak today. My name is Dr. Daniel Crawford. I've been a practicing neuroscience clinician specializing in childhood seizures for the past 14 years and a graduate nursing instructor for the majority of that time. I'm the immediate past president of the National Association of Pediatric Nurse Practitioners. Nurses have been recognized as the most trusted profession in America for 23 consecutive years. I can't imagine the U.S. vaccine development delivery system without them. Nurses trust vaccines. On behalf of more than 70,000 trusted nurse practitioners caring for our nation's children who ensure their own families are vaccinated, I want to be clear, vaccines save lives. Americans have trusted vaccines and the science experts at CDC and ACIP for decades because of the careful, evidence-based, and thorough manner of deliberating a vaccine science question. After observing the chaos of Secretary Kennedy's replacement committee yesterday, I fear that trust is gone. The HHS Secretary has called for gold standard science and radical transparency and medical freedom. And instead, we're seeing the opposite. The previous ACIP had a clear vaccine science question that had been posted and reviewed for months in work groups of specialists who used new data or clinical evidence to deliberate. ACIP would populate its work groups with practicing clinicians and researchers with deep vaccine knowledge. The prior work groups respected clinical experts partnering with CDC subject matter experts, brought their hard work to the ACIP voting members, and used methodological analyses in the evidence and recommended framework to discuss the specific question in the structured manner. The current committee removed experts from working groups. What we are seeing these past 2 days from the replacement committee was predetermined ideology with individuals appointed just hours prior who ignored subject matter experts and comments from clinical liaisons who care for patients. The replacement committee struggled to give rationale for the very reason hepatitis B vaccine was even on the agenda to the point it was tabled. Hepatitis B has one of the best safety profiles of all vaccines, and the birth dose has been used since 1991, preventing 99,000 deaths. The recommendation needs no changes. For the MMRV discussion, the freedom for parents and clinicians to choose was lost yesterday by the vote to remove the combined MMRV to children under 4 who want to lower the number of pokes, understanding the low and mild risk of febrile seizures. Parents are now confused and today questioning the MMR vaccine. The replacement committee took parents' medical freedom away without new data and infused fear that is already causing parents to question this long-proven safe and effective immunization. For COVID-19 vaccine, the trusted work group and ACIP committee would have reviewed COVID-19 vaccine data over the past year and presented at the June meeting, giving clinicians time to prepare for the busy back to school and fall vaccine season that we are now in. Because of the lack of trust in the replacement committee, our organization is now relying on outside experts from the Vaccine Integrity Project, the American Academy of Pediatrics, and the American College of Obstetricians and Gynecologists. And their reviewed data has showed COVID-19 is safe and effective in pregnant women and all children, and should especially be
that was over the 3 minutes. So the next speaker is Mrs. Patricia Armstrong.
Hello, good afternoon, and thank you for the opportunity. I'm just a 73-year-old woman with no medical or scientific background who wants her children and grandchildren and further generations to grow up safe and in a healthy world. I and many others are frightened. There is currently a war against vaccines, which save lives, but now they're called dangerous, poison, cause of autism, carry biomarkers, or alter our genetics. And because of this war, vaccination rates have been dropping. This makes our country and indeed our world less safe to live in. One result of this war is measles, once eradicated in our country, now making an unnecessary comeback. Even worse, our government clearly does not seem invested in vaccine science, developing new vaccines, or even providing the existing vaccines to the public. How to combat this? Get the public educated and involved. Then once educated, encourage them to contact their representatives, demanding access to all vaccines and a new investment in vaccine development. And what are these people afraid of? Points 1 and 2, formaldehyde and aluminum in vaccines. Why did I have to read on my own that a single pair contains more formaldehyde than any vaccine? And I wonder how many people don't know this. And is aluminum still used as an adjuvant since the creation of 3 or 4 new ones? Altering our DNA is number 3. I just learned a few days ago that after doing its job, the mRNA vaccine breaks down and leaves the body within 5 days to 2 weeks, and it's designed with no chance to alter our DNA. Why wasn't that explained when it started getting used for COVID? 4, causing autism. That was debunked years ago, and the doctor who spread that thought has been, I don't know what you call it, defrocked if he's a priest, because he faked the data. And biomarkers, a 5G marker is too large to fit through a vaccine needle, so it's not physically possible. Our institutions of health and science need to get better at informing the public and making the information easy to understand and disseminate among their friends and families. Make newspaper or magazine's article easy to understand with illustrations. Maybe ask a celebrity to interview you for free as a public service. To get people's attention, use all forms of social media with fun adult cartoons as illustrations and videos. Ask for discounts or freebies from videographers or illustrators to save money to accomplish these things. Get interviewed by honest podcasters, both conservative and liberal. The scientific communities need to move effectively, fight back against disinformation being spread, and it needs to happen before more people die from their own ignorance or from the ignorance
Thank you
of
for those
others.
comments. That was 3 minutes, greatly appreciated. And now it's Dr. Stephen Furr. Dr. Stephen Furr. We will go then to Dr. Richard Dang.
Hi, my name is Dr. Richard Dang, and I'm a pharmacist and associate professor at the University of Southern California. Americans deserve clear, transparent, and evidence-based recommendations from ACIP, CDC, and HHS that preserve access and respect individual medical freedom so that people who want protection can get it, and we can keep America healthy. Requiring a provider prescription for a COVID vaccine is unnecessary. We need practical access points across the healthcare system. Pharmacies are among the most accessible sites of care, with 90% of Americans living within 5 miles of one. And based on IQVIA claims data published by the CDC, pharmacies actually administered 90% of the total COVID vaccines in the 2024-25 season. People chose a convenient location and time, used their insurance, and were vaccinated without extra burdens. Today, this season's delay of ACIP recommendations, the issuance of recommendations without credible evidence by HHS, and the state variability in tying pharmacists' authority to prescribe and administer vaccines to the public have led to confusion and barriers for Americans. From the 2020 and 2021 rollout of COVID vaccines, we have learned that clarity, consistency, and timeliness in recommendations have real-world implications. I respectfully urge ACIP to 1, approve schedules and issue recommendations that are based on the best available evidence and avoid actions that limit choice or access. 2, uphold the gold standard process. Use the evidence to recommendations ETR framework and grade to keep recommendations anchored in evidence and transparency. And 3, maintain and protect choice for Americans who want to protect themselves or their family members from illness, transmission, and long-term complications from infection. With over 13 billion doses administered worldwide, COVID vaccines have been the most closely monitored of any previous vaccines and have demonstrated safety and effectiveness across the lifespan. Based on current evidence, anyone 6 months and older who desires protection should be able to receive the vaccine without added restrictions. For those who want to exercise their medical freedom and choose to get the vaccine, allow them the opportunities to do so. Pharmacists have the knowledge and training to work with patients who wish to receive a COVID vaccine and to evaluate the risks and benefits. Requiring a prescription because of ambiguous or non-evidence-based recommendations would strain an already stressed healthcare system, create barriers for patients, and risk deterring people who seek vaccination. Please help keep America healthy by preserving clear, evidence-based guidance and real-world access to these life-saving vaccines. Thank you for the opportunity to provide these comments today.
Thank you. And next is Dr. Stephen Furr. Do we have Dr. Furr? You are on mute. We will move to.
Can you hear me now?
Yes.
Okay,
Please go
thank
ahead.
you. My name is Dr. Steve Furr. I'm a board-certified family physician actively serving patients in a rural health clinic in Jackson, Alabama, while also serving as the board chair of the American Academy of Family Physicians, which represents 128,300 physicians. For more than 40 years, I've cared for patients, and every one of those years, I've provided vaccines for children and adults in my practice. Many of the vaccines we have today were not available when I started. Now physicians rarely encounter once common infectious diseases, but I'll never forget a shift during my residency when I stayed up all night monitoring multiple children suffering with Haemophilus influenza type B epiglottitis, listening to them struggle to breathe and hoping they wouldn't need to be intubated. Before the HIV vaccine, roughly 20,000 U.S. children contracted severe HIV every year, while 1,000 died from the infection. I haven't seen a case of HIV in decades due to the widespread use of HIV vaccines recommended by ACIP for decades. I want to share concerns about changes to ACIP that undermine trust and put communities at risk for real-world consequences like hospitalizations and deaths. Surveys consistently show that Americans consider their personal physician to be the most trustworthy source of information on vaccines. Excluding family physicians from participating in ACIP decision-making only weakens public trust in this group. Dismissing work group liaisons from the AFP has reduced transparency in the evidence and process used to make recommendations. The AFP strongly believes that among the membership of this board, there should be members who routinely counsel and provide vaccines to patients. We are concerned that the committee abandoned the evidence to recommendation framework that assesses both the risk and benefits of any vaccine. Because of these changes, the AFP believes ACIP's recommendations no longer addresses threats to public health, and therefore some AFP guidelines no longer align with ACIP's. The AFP will review this group's decisions on MMRV, hepatitis B, and COVID-19 vaccines, but without complete evidence and ETR frameworks, the AFP will have reservations adopting them. Narrowing MMRV and COVID recommendations reduces patient autonomy. Hepatitis B vaccines are critical at birth because hepatitis B infection is not limited to high-risk individuals. Children can be infected through any contact with blood from an asymptomatic infected person, including a small cut or any item with trace amounts of blood. The benefits of universal Hep B vaccination at birth far outweigh the risk of vaccination. We urge ACIP to restore and prioritize scientific integrity, transparency, and continuity in deliberation to restore public trust in the broader healthcare system. Thank you.
Thank you. Next speaker is Mr. Richard Su.
Hi, my name is Richard So. I'm the executive director of Hep B Free. We work on hepatitis B awareness and liver cancer prevention. For more than 6 years as the executive director, I've seen the real cost of hepatitis B and the liver cancer it causes in patients in the San Francisco Bay Area. And the stories are painfully consistent. I'm so glad I caught this, and I'm so glad I don't have to worry about this with my child now that immunization is regular at birth dose. You know, families who've lost someone say, if we only knew, it had known before it's too late. So universal birth dose, as mentioned by the previous doctor, has been critical for that so that no child falls through the cracks. There was mention that, you know, this is an STD or a sex-related or drug-related disease, but we know that the American healthcare system is fragmented and people fall through the cracks. And so this infant birth dose really shows that we can prevent those infections completely. And there's a long, long history of that success. Again, mentioned by other physicians, the Hep B vaccine has been one of the most safe and shown through data without any adverse side effects. So we really, though the issue was tabled, we really, really hope that remains the case. In addition, we know that if you don't vaccinate infants, there is that higher risk of infection, like on the playground, like bites and scratches. We know that infants are biting each other and getting into tussles, or caregivers maybe accidentally infecting folks, particularly because the Hep B virus is so infectious outside of the body. So this is a particular case in which many of those maybe perceived reduced risks are really, really serious. Finally, I wanted to note that when the Hep B birth dose was suspended historically, there was a lasting effect of folks not getting their infants vaccinated even after that recommendation was reinstated. And so there are long-term effects of changes to proven scientific choices that may cast doubt into the future for generations to come. So thank you for your time, and I appreciate you listening to community members.
Thank you very much. And the last public speaker is Wendy Liu.
Good afternoon. My name is Wendy Liu. I speak as a patient living with chronic hepatitis B. I support the Hep B universal birth dose vaccination to ensure newborns can receive the safe, effective anti-cancer and life-saving protection. My story is a harbinger of the lifelong disease burden for infants if they are not vaccinated and get infected. I was infected mostly at birth, likely at birth. It was before the vaccine was available. If a child is infected at birth, 90% of them develop lifelong chronic infection. And up to 25% of those will die from complications such as cirrhosis, liver failure, and liver cancer. I am in the 90%, and I am fighting not to be in the 25%. I know firsthand what it's like to live with hepatitis B and its long-term consequences. It means ongoing and lifelong medical needs. It means indefinite antiviral medication with no cure. It means ongoing time, money, energy, attention spent on navigating the healthcare labyrinth, insurance, specialty pharmacy, and recurring medical expenses. I live a life worrying about dying prematurely. Diagnosed with cirrhosis at one point, I didn't think I would see my children grow up. I went through a dark, dark period of mental health challenges. I worry about getting liver cancer. But you don't hear people talk about hepatitis B due to the misconceptions and stigma. I dealt with it in silence for decades. So hear me when I say this. I would not want anyone to have to experience this chronic, deadly disease, especially when it can be prevented. As a mother, I would do anything to keep my young ones safe. Thanks to the birth dose vaccine, my children are protected and prevented from Hep B. My mother experienced guilt for passing this to me. This is a burden that luckily I do not have to carry. In contrast, I feel relieved to know the vaccine worked. In closing, I speak as a patient, a mother, and a fellow American. I am saying no to what is not right. Do not open the Pandora's box to allow this silent, deadly disease to return. Do not inflict harm to babies and children when it's preventable. Most of all, I am saying yes. Yes to the world that I want to create. Let's prevent and eliminate hepatitis B infection. The Hep B vaccine saves lives and is our best tool. Thank you.
Thank you for that. And I would like to thank all of the public speakers. We will now go to the voting. We are, Dr. Hebel?
Yes, I'd like to make a brief statement, which is my own opinion, and that is that the evidence we have here is that we are not, as a committee, anti-vaxxers. The robust discussions of the science and the respect for each other's opinions and the inclusion of outside experts indicates to me that we as a committee do not come with predetermined attitudes or predetermined opinions, and that we are respectful to the public and respectful to other people. And I think the deliberations here are evidence of that and should be communicated as such. I think that understanding the risks and benefits of vaccines are critical to our process. And under that, it's very difficult to quantify the risks and benefits. The FDA is working at it, the CDC is working at it, and we're working at it. And we're going to do our best to communicate those risks and benefits.
Thank you for those
In
wise
a
words.
personal opinion-
We have to go to the vote right now.
Sorry.
And we will be able to have a debate for each of the votes. So I apologize for interrupting you there. We are going to change the order of the voting. So we're going to start with vote number 4. So if you can get that on the screen. So for vote number 4, do we have a motion to adopt the recommendation language presented?
Malone, so moved.
We have a second. So it's moved and seconded to adopt the recommendation language presented to the committee. I open debate on this motion. And we are restricting the debate now to members of the committee. So we can then vote. So I call for a vote. And please state your name and your conflict of interest and your vote. And we're going to start online this with Dr. Cody Meissner.
I'm sorry, Martin, I didn't get my hand up fast enough.
Or did you have if you want to debate, please do so. If you have something to say, please do so.
Yes. I wanted actually a point of clarification. Does this mean that adults 65 and older can go to a pharmacy and receive the COVID vaccine?
That's a good question. So the implications is that this will allow coverage with $0 cost sharing under CHIP, ACIP plans, Medicare Part B, etc., for all individuals aged 6 months and up. Also, it gives coverage from the vaccines for children for age 6 months through age 18. So this means that there is no insurance restrictions on getting this vaccine. So thank you for raising that. That is a very important thing.
And also, does that mean that a prescription is not necessary?
That is not part of this vote. That is part of a different vote, number 2. But that is actually not something that our committee has any power over. We don't have power over the budget of CDC. We don't have power of prescriptions. That is a state issue. We can only make suggestions. So that is not something that this vote is at all about.
Okay, thank you.
We will now move forward with the vote. And so please state your name, if you have conflict of interest, and your vote.
Starting with me? Yeah, I'm sorry. Do you want me to speak?
So please go ahead, Dr. Meissner.
Yes, thank you, Dr. Kaldorf. I think that as long as an individual-based decision-making does not need to involve a physician, I think a person at increased risk can decide for herself or himself. And so I would vote yes.
And did you have conflict of interest? State your name.
No conflict of interest, except I'm in that group.
And your name?
Cody Meissner.
Thank you for that. We have Dr. Pollock. Do we have you on the phone?
Hello, can you hear me? Can you hear me?
Yes, we can. Please
Yes,
state your name, conflict of interest, and your vote.
Raymond Pollock, no conflict of interest, vote yes.
And Dr. Malone?
Malone, no conflict of interest, yes on vote for.
Dr. Pagano?
Yes.
Dr. Malone?
Kirk Melhone, no conflicts, yes.
Dr. Blackburn?
Hillary Blackburn, no conflicts,
and I vote yes. And to clarify, pharmacists are included in that shared clinical decision-making.
Thank you. Dr. Stein?
Kathy Stein, no conflicts and vote yes.
Dr. Griffin?
Evelyn Griffin, no conflicts of interest. I vote yes.
Dr. Hibble?
Joseph Hibbelin, no conflicts of interest. I concur with Dr. Blackburn and Dr. Meisner regarding pharmacists, and I vote yes.
Dr. Pepsworth?
Vicki Pebsworth, no conflicts of interest. Yes.
Dr. Levi?
Recep Levy, no conflicts of interest, yes.
My name is Martin Kuldorf, no conflict of interest. I vote yes. We have a vote, 12 yes, 0 no, and 0 abstain. So it is passed. We will now move forward to vote number 1. Thank you for having that on the screen. For vote number 1, do I have a motion to adopt the recommendation language presented to our committee?
So moved, Kirk Milhoan.
We have do we have a second?
Second.
Thank you. That was too fast for me. It is moved and seconded to adapt the recommendation language presented to the committee. I open debate on this motion.
Yep, Cody Meissner.
So I have a comment. Dr. Meissner?
Yes, thank you. And I just want to clarify again what this means. Does that mean an informed consent must be obtained?
So can I clarify what the intent?
Please.
Yeah, so I think that the idea here is to send a very strong message and a recommendation that it has to change the way it communicates with patients and medical providers about the risks and uncertainties of the vaccine. And that includes the vaccine information statement as well as other communication channels. We don't intend to prescribe to the CDC exactly what language to use. We express our strong desire that that should be done to ensure appropriate communications and including as part of informed consent. And that's kind of how we should view that this recommendation, I think.
Can I comment?
Dr. Hibble?
Briefly, with regards to your question of requirement, the way I read this proposition is that the CDC engages in an effort to provide more consistent and comprehensive language. I do not see the word required in this proposition.
And it says considers as well.
Dr. Malone?
Yeah. It is not within the purview of the federal government or the CDC to regulate the practice of medicine. That includes the practice of informed consent. That's a states' right issue. The intent here, as I understand it as a member of the working group, is to encourage the CDC to provide information which can be used by states to support informed consent processes should they so require. Does that help, Cody?
And specifically, the vaccine information statement is a document that is being generated and updated by the CDC. So that's something that is also relevant.
Yeah, in this paper that Recep listed in his presentation, there's a very clear, was it Kaplan, senior author? Very clear enumeration of the long history of the interaction between states regulating practice of medicine and informed consent, the vaccine information sheet, and the CDC. It's complex, and it's very clear that the federal government doesn't have the right to regulate any requirements having to do with informed consent, but that the CDC has kind of stepped into the breach inadvertently, in part due to needs to mitigate legal liability. So it's really convoluted at this point, and we're just trying to make it incrementally better.
Yes, and
hold on. I had also put myself on the list. So normally this type of votes are not done by the ACIP. It's usually done by CDC. I have full confidence in both the CDC staff and the CDC leadership, including the CDC director, that they are able to take the discussions that we've had today and to do this on their own without us having to make a vote to recommend it. I think there was a lot of wisdom in the words said today, and I think the CDC staff and leadership has the capacity to do that on their own.
Can I respond to that?
Martin. We have Dr. Meissner.
Okay, thank you. We've got a long line here. Thanks for that clarification to everyone. And so a vaccine information sheet is already required by law for every vaccine. So what will change here is the content of the vaccine information sheet. Is that correct?
Yes, yes. We suggest that the content will be changed. And again, the CDC will have to apply their judgment about how to do that exactly, given this suggestion that we are making here.
Fine, thank you.
Thank you, Dr. Bruman.
Thank you for recognizing me. I'm sorry. I think it's been covered. It sounds like usually vaccine recommendations are measurable and policy related, and this type of thing is usually a clinical part of the clinical recommendations that are in the text of a recommendation. So I just also want to make sure we clarify what is meant by it is the sense of the committee, because we want to be obviously really clear that everything that we describe and discuss and recommend is evidence-based. Thank you.
So
Dr. Levi?
Yeah, I would like to address it. So a few thoughts. First of all, I believe that it's appropriate and actually necessary that ACIP will think about vaccination policies related issues in a broader sense than just focus on a very specifically narrowly question of whether to and how to recommend one vaccine or another. That's within the charter of the ACIP. I actually looked at this. Secondly, as much, I understand the trust, we all trust the CDC, but the fact of the matter that the current VIS of the COVID-19 vaccine does not reflect the current risk as we discussed today, by no means. So I think it's important to make that statement. And I think that all the risks that are articulated there were formulated, or the issues were formulated after deep literature review and deliberation about what the evidence suggests. And I also would like to make the last point is, when we think about communicating to patients, we don't need to wait until there is absolutely 100% of evidence of harm. We need to be transparent about the risks and uncertainties that we have. And if we don't know something, or we suspect something, or we have missing information, that should be communicated to them. And just an example is something that Dr. Meissner, you mentioned, like our understanding of what protection this vaccine is giving to different people is very lacking, to say the least, and it's based on low quality evidence. We need to be honest and transparent about this. I think that the evidence suggests that we have not been that way. And I think that we, as ACIP, we should call it out and make a very explicit statement about that. I think it's not only appropriate, I think it's actually something that is in the core mission of what we are supposed to do.
Is the committee ready to vote on the motion?
I move for a vote.
So the vote is listed here in the front of you. I will start. Please say your name, conflict of interest, and your vote. Dr. Meister? Yeah, you are on mute. I'm sorry.
Thank you. Cody Meissner, no conflict, and I vote yes.
Dr. Pollock?
Dr. Pollock here, no conflict. I vote yes.
Dr. Stein?
Kathy Stein, no conflicts. I vote yes.
Dr. Blackburn?
Hillary Blackburn, no conflicts, yes.
Dr. Milhon?
Kirk Milhon, no conflicts, yes.
Dr. Pagano?
Dr. Pagano, no conflicts, yes.
Dr. Malone?
Malone, no conflicts, yes.
Dr. Griffin,
Evelyn Griffin, no conflicts. I vote yes.
Dr. Hibble,
Joseph Hibbelin, no conflicts. I vote yes.
Dr. Pepsworth,
Vicky Pebsworth, no conflicts, yes.
Dr. Levi,
Retzef Levy, no conflicts of interest. I vote yes.
Martin Kulroff, no conflicts of interest. I vote no. We have 11 votes for yes and 1 vote for no, so this motion passed. We will now move on to vote number 2.
I move to make an amendment.
First, we have a proposal for an amendment. Dr. Blackburn.
Yes, to strike the require a prescription. That is, unless CMS is ready to authorize pharmacists as Part B providers. But I guess we're not able to make that decision right now, but to strike the require a prescription.
So again, could you explain more what you mean? Sorry, I'm not sure I
Oh.
follow what your suggestion is.
We're not currently authorized as providers in Part B language, and so we can't currently write a prescription. So
In some states,
No,
pharmacies.
we cannot write a prescription. We can operate under a collaborative practice agreement in most states, but it would be a barrier for access if a prescription was required.
So is your suggested to make an amendment, or you are arguing to vote a no?
No, just to amend the require a prescription.
Doesn't make sense.
That rather is the core of the vote.
All right.
So it's, unless you have specific language to amend it, I think it comes down to a yes or no vote.
Okay.
Well, she can, I mean, she
No,
has the
yeah,
right
it
to
seems
amend.
to suggest that you want to vote no on this. And is that okay to have it like that? Okay, good.
Further vote?
We have to first do, is there a motion to adopt?
I just want to say something about this before
We will have the debate after we
Oh,
have
okay,
done that. So is there a motion to adopt?
Sure, motion.
Motion. Second.
So it's moved and seconded to adopt the recommended language presented to the committee. I open debate on this motion. Dr. Stein?
I am all about informed consent, and I think given the earlier discussions about risks and benefits and unknown risks and unclear benefits, I think that discussion is really important, but I'm really concerned about the requirement of a prescription because I believe the segment of the population that is underinsured, has lack of access to healthcare, they're going to be unable to get a prescription. And those are the people that are at highest risk for a lot of these comorbid conditions. And so I just, that's my only concern.
Thank you. We have Dr. Meissner.
Yes, thank you. And I'm strongly opposed to a requirement for the prescription. I think the point that was just made is an accurate one. And remember, the vaccine information sheet will include most, if not all, of a discussion that would take place with a physician. But I think requiring a prescription is going to become a big barrier to administration of this vaccine. And if a person wants it for himself, herself, her children, they should be able to get it without a prescription. Over.
Dr. Hibble?
We are going for comments then.
This is a debate, Dr.
Yes,
Hibble.
very good. I am also concerned, as it is my understanding that approximately 30% of Americans don't have access readily to a primary healthcare provider. It's my understanding that in Texas and more rural states, it can be an even higher barrier, and that inability to access a healthcare provider secondarily impairs the ability to have a risk-benefit discussion with your provider. So I think that I concur with Dr. Blackburn, Stein, and Meisner that this would present a significant barrier to implementing all of the good things we've discussed.
Thank you, Dr. Levi.
Yeah, a few thoughts. So first, just to put it in context, I think that this vote is about leaving this to every state to figure it out, and the state can decide not to do it if it's going to indeed limit access. But I just want to talk a little bit about this access. So we are saying that people that don't see their medical, don't have access to medical. So how would they get antibiotics? Why? Based on that logic, right? We would need to also allow taking over-the-counter antibiotics and other prescription drugs. Now, why we don't do that? We don't do that because we believe that the prescription of these interventions requires some nuanced assessment of the medical condition of that person to actually decide whether it's appropriate for them or help them decide whether it's appropriate for them to take it. I believe that given what we heard today, it's true about the COVID-19 vaccines. And if we believe that this is really a nuanced decision-making and that there should be a conversation with the patient that is deep, I think that it's very strange to me that then we say, we don't require this for that particular product. We are not talking about any vaccine. We're talking about this particular set of products. We just discussed how nuanced it is. And I don't see why this is different than any other prescribed drugs. Like the same argument could be applied. Now, most of the people that are actually in risk for COVID, severe COVID, are presumably under other drugs that are being prescribed to them. And they see the doctors either for care or for renewal of their prescription on a regular basis. So I have to say that I understand that this is maybe kind of an instinct that we have or saying about access, but I'm not sure when you actually think through the rationale here that is holds a lot of water. So I think we should actually go ahead with this.
Dr. Griffin? Dr. Griffin?
Thank you. Yes, I am very conscious of limiting access. Dr. Levy just took the words out of my mouth much more eloquently. I have to agree with his comments. A very big proponent of informed consent, and I feel that would, getting a prescription would require that or necessitate that interaction with a provider that can discuss informed consent, much like getting a blood pressure medication refilled or started. And so I concur with Dr. Levy's comments, and I feel like the issue of access may be a separate one from that of informed consent. And I feel like we should work on that as a separate problem. Thank you.
Dr. Meisner?
Yep, thanks. First of all, I'm a little uncomfortable, Retzef, with the analogy between an antibiotic and a vaccine. An antibiotic means that somebody's sick and they need to be seen by a physician to decide which antibiotic and whether or not an antibiotic is necessary. That's a relatively urgent setting. A vaccine is generally administered to an otherwise healthy individual, and if we require a prescription, we're going to increase healthcare costs, and I don't think this is a reasonable basis to do that. I think if a person wants to get the vaccine, a physician is not going to talk her or him out of getting the vaccine. So I don't see what purpose it would serve. Over.
Dr. Malone?
In fact, what we are talking about, because the restrictions associated with the FDA authorization or licensure, is that they have largely restricted availability to those with one or more comorbidities. So these are people that are not actually healthy. So the assertion is that we're talking about healthy, normal adults is not true, verifiably not true. We're talking about people who are at high risk with a variety of conditions. Presumably, hopefully, they are seeking medical care of one form or another. We're also speaking about, in the Contra case, we're talking about hypothetical situations and speculation about impact on accessibility that has no information behind it. It's based on feelings. What I am with Dr. Griffin, that these products have the appearance of significant risk in a variety of forms. Whether or not the risks outweigh the benefits is what's on point here. And that is clearly a very nuanced issue having to do with individual patients. So the requirement for informed consent is basically a requirement that some competent individual works through the risk-benefit ratio for that individual patient, and that individual patient is making an affirmative decision together with their healthcare provider as a consultant, that this is the best path forward for them, as opposed to somebody who is subjected to propaganda, marketing, and other activities that are not based in a actual real-world assessment of their risks and benefits. So for me, I prefer to err on the side of an actual prescription after a discussion with a licensed healthcare provider that is well qualified to serve in a partnership role with the patient in making a assessment of risks and benefits based on the medical condition of that patient. Over.
Comment on that.
Okay, please, Dr. Blackburn.
To clarify, pharmacists are licensed healthcare professionals. And we do complete a full coursework that includes a full immunology course, and are actually one of the only clinician types to complete a standalone national immunization delivery certificate, which reviews disease background, immunologic response, and how to conduct individual patient risk and benefit assessment for vaccines, plus hands-on assessment. And I was given some additional information. So in the slide deck from earlier, there was a slide showing the 67% reported pharmacy access. That was from a 1-month time period. But according to claims data for total doses administered for the 2024-2025 season, 90% were given at pharmacies, 27,569,515 doses at pharmacies out of 30,775,189.
Can I respond?
Dr. Meissner?
Yes, thank you. When I want to see my internist, I have to wait a year. I can't see them more than once a year. So that means it's going to be very difficult to get a prescription, and it's essentially going to be a barrier for people to have access to this vaccine. And that is not the role of ACIP. So, and number one. Number two, maybe I misunderstood, but I thought we had already said that a person who's in a high-risk group or who's over 65 can get it without a prescription. Does this apply to everyone, or is this just to otherwise healthy people?
Dr. Malone?
I don't have any opinion about whether pharmacists are qualified or not qualified, and I certainly wasn't implying that. That's a matter of state law. And I'm just, if a well-qualified healthcare provider of any condition is authorized by their state or local jurisdiction to make a determination in the form of some sort of prescription authorization, that's up to the state. I'm not, and this particular language is really pretty squishy. It's the sense of the committee that state and local jurisdictions should require a prescription for the administration of this particular product. So I yield to Dr. Levy.
Dr. Levy?
Yeah, so just to echo 2 points. First, I think that pharmacists definitely should be considered as a very good solution. I think that in my understanding, we checked that over 40 states currently, they will be able to do it even in the current state, and every state will have the ability to allow this to happen. That said, I also want to say that in my experience of getting vaccines in the pharmacy, nobody ever talked to me about any risk and benefits, and they just handed me some, at the best, some form that I haven't read, and I just go and nobody even gave me time to read. So I guess that part of this is saying and sending a message, there should be some conscious action here of someone has to explicitly document that they give you the intervention. And I think that the paper that we cited earlier today is talking exactly about that. So my point is, we are making an aspirational statement here that is guiding the states with finding a solution. And I think in all likelihood, every solution that the state will find will involve pharmacies for practical reasons, whether they decide not to adopt it because pharmacies cannot adopt it, cannot do it in their state, or change the state rules to allow pharmacies to do it, or in most states, pharmacies already can do it. So practically, I don't think when you actually look on the practicality of this proposal, I don't think it's going to lead to any access problem because most states have a solution. The states that don't have a solution can either find a solution based on pharmacies or reject that. So in all honesty, I think the message here, the current informed consent process is broken. And in pharmacy, and I suspect not in pharmacies, right? We just give these products essentially over the counter. And we are not talking about any vaccine. We are talking this particular vaccine that we heard about all the risks and the uncertainties there with very low, questionable benefits for a lot of people. So that's kind of, I think, how I view this vote.
Yeah, well, historically, at least 19 states have required pharmacist authorization to be tied to ACIP recommendations. And so a lot of the states have been making their own recommendations to help clarify some of the confusion, which has been limiting some of the access, as we've seen with CVS and Walgreens pulling their COVID-19 vaccines for the season.
Retz, if you need to get a new pharmacy, if they don't ask you about allergies or reactions to vaccines.
I tried a few of them, including...
Please only speak when I ask you to do so. Dr. Hogue, please.
If we're talking about personal experience,
please, we will have Dr. Hogue has been requested to speak. Or if not, we are now going to go to Kelly Gude.
Yes, thank you for the opportunity.
Sorry about that. Was there a question for me? I apologize. I couldn't get the unmute on.
I think it was requested. You had requested to speak, but if you're not, that is perfectly fine.
No. Sorry to interrupt. No, I did not.
Okay. Does Kelly Gude have requested to speak?
Yes, thank you for the opportunity to speak. Kelly Good, representing the American Pharmacists Association. I'd like to just clarify a couple things. First, that in many states in the U.S., the authority for pharmacists to give vaccines is based on an ACIP recommendation. So if an ACIP vote is that they have to have a prescription, then they may not be able to administer the vaccines because that may be determined that it would have to come from someone else that would write the prescription and not the pharmacist. Pharmacists are the most accessible healthcare provider who have relationships with patients and are well equipped to determine risk based on medications and health histories. Furthermore, pharmacists are the healthcare providers who have the most experience with COVID-19 vaccines. Claims data show that 90% of COVID-19 vaccines have been given in pharmacies. Dr. Blackburn talked a little bit already about education. So requiring a prescription for COVID-19 vaccine will decrease access for patients, will highlight healthcare inequities, especially for patients who may not have access to any other healthcare provider in their communities, and decrease individual patient choice. A prescription is not needed and will cause unnecessary steps to access. Pharmacists are qualified to regularly assess risk and balance it with benefits for their patients. Thank you for the opportunity to speak.
Dr. Middleman?
Thank you so much. I just want to clarify, I'm very concerned because after 21 years on the committee, it has always been clear that vaccines are a primary prevention public health strategy that is remarkably different from treatment with antibiotics or treatment for patients who are seeing providers on an individual basis. This is why a lot of the policy that currently exists around vaccines exists. If we start asking for prescriptions for vaccines, which are, again, a primary prevention public health strategy, we are going to overwhelm physicians' offices. As a practicing physician, I'm sure others will agree with me. I'm not even sure what you mean by a prescription, because when patients come to the doctor, there's an order, there can be standing orders. We don't send anybody with a prescription to the pharmacy. They can get it at the pharmacy. And so I'm not even clear on what this is about, but what I can tell you is that it's alarming to me that for a primary preventive strategy, we are actually adding access concerns and barriers rather than diminishing them. I think that this is a really important piece of improving public trust in vaccines. The job of the committee is to assess the risk and benefit as a public health strategy. That's been done. So we should make it available and accessible. Thank you.
Thank you. We have already is way beyond the time. We should have finished quite some time ago. If we are able to vote on this, depends on how many more people want to discuss it, how long they take. We have, I'm talking, please. Dr. Malone, please.
Point of clarification, do we have a modified amendment or not? And if the amendment as written stands, I move that we proceed to a vote. Over.
We don't have an amendment.
I second that
we also have Dr. Merling.
Yes, thank you. The Association for Prevention, Teaching, and Research. I just want to echo what my other liaison representatives and what Dr. Blackburn has so thoroughly stated is just, and really urge the committee to really think about how this will impact access. And that if pharmacists are the ones that the majority of patients are going to obtain their COVID vaccine, and if the committee, as they voted to pass the vote in vote number 4, are allowing for that choice and individual decision making, again, with vote 1 being that we have this more informed consent process, which I'm all in favor for. Maybe perhaps also our CMS representative can speak a little bit more to what this requirement of prescription would mean for limiting pharmacy ability to give this vaccine. Thank you for taking my comment.
So motion
Thank
to
you for
vote
that.
again.
Thank you for that comment.
We
Is the
have a
committee
motion
ready to
for vote, right?
Can you please, I'm talking now. I'm the chair of this meeting. And that's the only way to finish is if you let me do that. Is the committee ready to vote on the motion?
I move that we vote on this motion.
I second that motion.
That has already been passed. I call for a vote. Can you please state your name, conflict of interest, and your vote? We will start with Dr. Meissner.
Cody Meissner, no conflict of interest, and a strong no here.
Dr. Pollock, who is by phone.
Dr. Pollock, Raymond Pollock here, no conflict of interest, vote no.
Dr. Pagano, also on the phone. Do we have Dr. Pagano on the phone? We will return to him. Dr. Stein.
Kathy Stein, no conflicts, vote no.
Dr. Blackburn.
Hillary Blackburn, no conflicts, strong no.
Dr. Milhoan.
Kirk Milhoan, no conflicts, yes.
Dr. Malone.
Malone, no conflict of interest, yes.
Dr. Griffin.
Evelyn Griffin, no conflicts of interest. I vote yes.
Dr. Hibbeln.
Dr. Hibbeln, no conflicts of interest. I vote no.
Dr. Pepsworth.
Vicki Pebsworth, no conflict of interest. I vote yes.
Dr. Levi.
Retzef Levy, no conflict of interest. I vote yes.
Dr. Pagano.
Dr. Pagano here, no conflicts. I vote yes.
My name is Martin Kulov, no conflict of interest. I vote no. We have 6 votes for no. We have 6 votes for yes. Since it's a tie, the chair breaks it. I voted no, so the motion has failed. We now have number 3. We are half an hour over time. We have 2 options now because people are going to the airport. My view of this motion is that it's, I agree with everything, just like I agree with apple pie, motherhood, and fatherhood. If we can proceed to this vote without a discussion, I think we have time to do so. If a discussion is necessary, we might have to table the vote. So first of all, I would say, is there a motion to adopt?
So moved.
Second.
Thank you. It is moved and seconded to adopt the recommended language for this motion. Is there a debate?
Motion to vote seconded.
Is the committee ready to vote on the motion? There were no objections, so we proceed to vote. Please state your name and if you have conflict of interest and vote. We're going to start with Dr. Meissner.
Yes, I've hardly had a chance to read it. Cody Meissner, no conflicts of interest, and
we can go back to you if you want.
Yes, could you come back
to Dr. Pollock?
Raymond Pollock, no conflicts, vote yes.
Dr. Pagano?
James Pagano, no conflicts, yes.
Dr. Stein?
Kathy Stein, no conflicts, vote yes.
Dr. Blackburn?
Hillary Blackburn, no conflicts, yes.
Dr. Milhouse?
Kirk Milhouse, no conflicts, yes.
Dr. Malone?
Malone.
Dr. Kohler, I don't know if you can hear me. I can't. Somehow I've lost the connection.
Hey, Cody, it's Amy Middleman. I think we've all have.
Thanks, Amy.
Looks like they cut the feed.
They probably lost the time. This is Phyllis Arthur with Bio. I did email Dr. Zadeh to say that we lost sound right when Dr. Malone was voting.
How are you going to vote, Cody?
Dr. Meissner?
Yes.
Can we have your vote, please?
Thank you. I've been waiting patiently. My understanding is the healthcare provider can be a pharmacist, and as long as the pharmacist, this isn't going to place undue weight, burden on the pharmacist, then I would vote yes.
Thank you. And since I have to vote last, I'm just going to repeat my vote. Martin Kulldorff, conflict of interest, no conflict of interest, I vote yes. So we have 12 votes yes and 0 votes no. So the motion is carried. So I would like just to thank everybody for spirited discussions, both within the working group, the public comments, the liaison members. I would like to thank the CDC staff. I would like to thank the representative from the media who are coming here. I would like to thank all the viewers, listeners who did this online. I would also like to thank the staff here at the CDC, who sort of took care of all the logistics, the security details, and so on, who has done a great job always smiling to us as we arrive. So I would like to thank all of you. And this concludes this meeting of the Advisory Committee on Immunization Practices. Thank you.
Thank you. You guys have to. Brad is going to take you to the freeway. Do you need this for the airport? Sure.